Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. We're so excited today to have this event related to the release of our June issue, Reimagining Public Health. There's been a lot of really terrific work done by individuals and organizations to discuss the importance of rebuilding the American public health system, particularly in the wake of the COVID pandemic. What excites me particularly about the issue that we just released on Monday is that we took it a step further and asked our authors to reimagine public health, to think somewhat more expansively and perhaps differently about what's needed, so that we don't just reconstruct what was or fill in a few gaps that existed, but think more holistically about what's important in supporting population health. And if I may say so myself, I think the issue has done exactly that. I'm very excited about the content, and we're confident it will provide a nice roadmap for people for many years ahead. So let me just say a few words about how the event will proceed today, and we'll get straight into it. We have a lot of content to cover, and I want to save most of the time for that. We've divided the content of the issue into 4 panels. The panels are not perfectly divided. The content never does it quite that easily, but it helps enable a conversation. And so we start with some broader papers on the dimensions of public health. We have a series of papers on the workforce. We'll move into sustainability and accountability. And the final panel will look at public health and the community from quite a few different dimensions. We always get asked this, so I'll just say it here and again a few times. This event is being recorded, and it will be available on our website within just a couple of days. You'll note also that this event is just part of what we do to promote the issue. We'll have podcasts and discussions with some authors and other events. You can find all of that at www.healthaffairs.org. Before we move into the content, a few words about what it took to make this issue possible. We're particularly appreciative of the funders for the work that made it possible to publish the papers and hold events like this and others. We're grateful to the California Endowment, the Robert Wood Johnson Foundation, Kaiser Permanente Fund at East Bay Foundation, the Big Cities Health Coalition, and the Public Health Accreditation Board Center for Innovation. All of them provided financial support for the issue. We want to thank our theme advisors, Monica Bharel of Google and Ross Brownson of Washington University at St. Louis. Internally, our theme issue editors were Leslie Erdelak and Michael Gerber, although many, many others were also involved in putting the issue together. If you're watching this live, you do have the opportunity to ask questions of our speakers. There's a Q&A button at the bottom of your screen. You can submit questions during the panel. I'll do my best to weave those questions into the conversation. I want to warn you that time is very limited, and I'll probably only be able to get to a few with each panel, but I encourage you to submit questions that you think would be of general interest, and to try to do so as early as possible so I have time to read them before we get to the Q&A section. With that introduction, I'm pleased to devote the vast majority of our time over the next couple of hours to our authors. They've each been asked to present their papers, and then we'll have some time, as I noted, for Q&A. Our opening panel will be with Jonathan Samet, professor and former dean and interim department chair in the Department of Environmental and Occupational Health in the Department of Epidemiology at the Colorado School of Public Health. Monica Bharel, clinical lead and of the public health sector at Google. Michelle Mello, professor of law and professor of health policy at Stanford University Law School. I know having a moment of technical challenges, but I assure you she'll be here in time to present the paper. And Katelyn Long, a postdoctoral fellow at the T.H. Chan School of Public Health at Harvard University. All 4 of these papers take a higher level look at what public health is and what public health needs to succeed. And I'll turn now to the authors in turn to present. First, over to you, Jonathan Samet.
Okay, thank you, Alan. And on behalf of myself and Ross Brownson, we're pleased to be able to present our work. And I want to give particular thanks to Ross, my colleague, and thinking about the path forward, and also to a number of prominent figures in public health who worked with us and gave us their thoughts about the future to help us shape this paper. We can go to the next slide. This is hardly the first time that there have been collective thinking about the future of public health and where it should go. I'll note a few probably very well-known reports to many of those of you who are listening. I will point out that as early as the fall of 2020, Ross, myself, and others had put together a paper using the reimagining word as the pandemic was still in full force. Clearly, at that point, months in, we had a clear understanding of some things that were going well and too many things that were going wrong as we tried to manage the pandemic. Next, please. So in terms of the moment, and we are here and the issue is with us because of this really critical moment in public health as we have 4 years of lessons learned from a pandemic that swept across the United States and of course globally. We learned a lot about what our, and I have it in quotes, our public health system can do and what it cannot do. And of course, fundamental to some of the problems in the United States was the fact that we have a system that ranges from thousands of local public health departments up to various national entities. So Ross and I propose that we are at one of the most propitious moments for true transformation. We have the motivation. And at the same time, I think reality says that we have to acknowledge that the forces countering public health actions have never been stronger and certainly invigorated by certain happenings during the pandemic. Next, please. In thinking about a framework for reimagining or transformation, we highlight 7 areas that we categorize as contextual, topical, or technical. These are not new issues, but at the moment, thinking about reimagination or transformation, they came to the top of our list in terms of priorities and points where action was needed. We'll hear later a presentation that talks about accountability. Accountability is complementary to addressing the politicization and polarization that has sprung up around public health. And here we see a need to say what it is that public health has done in ways that people understand it, and to speak to those who are perhaps leading this polarization around public health. Climate change and health is an emerging area and one that has been discussed now for several decades, but the realities are upon us, and that can be manifest in so many ways, whether it's heat waves that lead to countable deaths, wildfires, certainly a problem here in Colorado, drought, food insecurity, changes in vectors, and much more. And this will require action that does truly range from local to global. Equity, of course, has been with us. It was a key part of Public Health 3.0, but it remains with us. And as we learn more and more, I think we have learned that public health needs to address the structural processes that are barriers to bringing health equity for all. Technical areas, an easy one, data sciences, and again, we'll hear more in this panel, but truly we are at a transformative moment. As somebody who began my career using punch cards, we've come a long way, and we need to incorporate these advances into what we do in public health at all levels. Our workforce has been battered by the pandemic and needs to be rebuilt. It needs to be rebuilt with resiliency to contend with the new penumbra around public health, And it needs the new skills, for example, to use the tools of contemporary data sciences. And last, to use the new world of communications that unfortunately brought too much misinformation too quickly to the public during the pandemic. We need to be better equipped in our communication capacity. Next. So in our paper, we cover a lot. And there's, of course, a big agenda, and we're going to hear about that as we go through the presentations today. But we see priorities should be given. Data sciences, the need is clear, the tools are here. We need leadership and, of course, inevitably funding. Politicization and accountability need to be on the priority list. They're interrelated, they're cross-cutting, as I mentioned, and critical to moving forward with any change. And last, workforce development, urgent. We need to provide new skills and resiliency. And here we see a role for the academic public health department model. Next, please. And so in conclusion, we see that this is the time for change, and we see the need to benefit the public health and moving forward with transformation. Last, the inevitable quotes from Yogi Berra on the last slide, if it's there. And if not, I will, if not, just again, these quotes will stand. There will be reports, inevitably, future issues. And I think we need to take advantage of this moment of transformation. It's not over. Thank you.
I'm thrilled to be able to give you a short presentation around transforming health using public health practices with generative AI. I'm pleased to be speaking on behalf of the other authors as well, Karen DeSalvo, Von Nguyen, and John Auerbach. So the COVID-19 pandemic proved to be a global stress test on our public health infrastructure. I was running the Massachusetts Department of Public Health during that time and saw firsthand that timely and actionable data from across sectors allowed us to make population-level decisions that were evidence-based and equity-focused. Many health departments are working to modernize their data infrastructure as a result of these experiences. Add to that over the last 2 years, generative AI has been advancing rapidly and can be a part of this transformation for public health. In the commentary that we provide in this issue, we discuss some current uses of AI in public health and suggest some early uses of generative AI in the public health realm. We also review the potential challenges and risks. Artificial intelligence is the development of computer systems that can perform tasks traditionally performed by humans. Generative AI is the ability to generate new content, such as language and images. AI is already present in our daily lives, suggesting the next song we should listen to or the next string of words in our email. It has also been used in public health, for example, during the pandemic for COVID-19 forecasting purposes. With the introduction of generative AI, how can public health safely and responsibly take advantage of this new capability to improve health? Integration of technology works best when it helps improve daily work functions. In this commentary, we lay out some of these opportunities using the foundational public health service framework, which lays out our essential core services in public health, the daily work of public health. The updated framework emphasizes equity, data and technology, social determinants of health, and workforce. If I could have my slide up, please. Thank you. We break this up into 3 buckets of public health essential work: communications, operations, and data insights. With each one of these, we envision that there is always a human in the loop using the potential of generative AI to improve health. Let's look first at that first bucket of communications. Educating and informing the public is an important role of governmental public health. Getting people the right level of information in the right language, on the right platform, at the right time. I know I would spend a lot of time with my communications team figuring out how best to reach residents with vital health information in their preferred language and preferred platform. With Gen AI's ability to generate text, this allows our communications teams to deliver a more personalized and relevant experience, even in limited resource settings. Looking at the second bucket, operational performance. How can Gen AI help our staff perform more effectively and efficiently so that everyone can function at the top of their license? For example, my analysts at the Department of Public Health were very capable of taking in lots of data and making great policy or program suggestions. However, they were often inundated with data points and not enough time to reflect on the implications of this data. An analyst who would normally spend 3 days reviewing proposed regulations and hundreds of public comments, an analyst would often spend 3 days looking at these regulations and hundreds of public comments. Often, many of them would be duplicates. That analyst can now potentially use Gen AI to consolidate this work and then apply it to smart programming and policy suggestions. In the last bucket of novel insights, we can use Gen AI to incorporate unstructured data and data from different sectors to find relationships and interactions around health that we haven't seen before. We can do a better job of understanding where the current need is greatest so that we can target our limited resources. We can understand what cross-sector intervention is likely to have the greatest impact and to be able to measure and report on our outcomes in a precision public health manner. Exploring these early opportunities to use Gen AI to help improve public health will help public health professionals be engaged in the further development of these tools and be active participants in addressing the potential challenges, such as ensuring transparency on what data is being used to train the models and the proper inclusion of data that covers historically marginalized groups. There's great potential opportunity here, and we need for public health to be engaged to further improve these tools and have them be capable partners in our work to improve health as we think about reimagining public health. Thank you.
Thank you, Monica. And we'll move now to Michelle Mello.
I'm really pleased to present this joint work with Wendy Parmet from Northeastern University and David Jung at Stanford. This work was funded by the Commonwealth Fund, which shares our interest in trying to understand the lasting legacy of the COVID-19 pandemic for public health law. There was just an extraordinary burst of litigation challenging health orders during COVID-19, and this amounted in most cases to a series of government victories. And a previous study found that in about 3/4 of those challenges, the government actually prevailed. This study is about the 1/4 where it didn't. We were interested in focusing on cases where plaintiffs prevailed on at least one of their claims, even if it was at an early stage of the litigation and not a final adjudication, because these decisions will constrain public health officials going forward. They are good law. In many jurisdictions, they cut across the country, as we'll talk about, and they may have important impacts on the degree of latitude or maneuvering room that health officials have, both in future health emergencies and even outside health emergencies. Next slide, please. So to identify these lasting effects, we searched through over 1,700 judicial decisions challenging community mitigation orders, by which I mean things like vaccine mandates, certification requirements, mask mandates, business and school closures, gathering restrictions, and stay-at-home orders. We found 112 that met our criteria of constituting a plaintiff victory in the sort of final word decision in the case on a particular issue. And we conducted a systematic content analysis of those 112 decisions. They span both federal and state courts over a 3-year period. Next slide, please. Here's just a snapshot of what these claims look like. As you can see here, the most common types of legal claims on which a challenger to a COVID-19 order found success had to do with religious liberty, free exercise of religion under the First Amendment, or claims that an agency official or a whole agency had exceeded the power for emergency management that some statute, some legislative enactment gave them. Often these claims were against CDC, but many of them were against state and local health agencies as well. Often pretty common in the sample were claims that somebody had been denied due process of law, either by being deprived of property or liberty without fair procedures, or by having the government invade a zone of their protected liberty without adequate justification. And as an aside, the decisions in these cases really cut across all levels of court. 9 of them were US Supreme Court decisions, but 58% were from trial courts, the lowest level of court. And when we looked at the types of health orders at issue, the most common challenge was, as you might expect, was to restrictions on gatherings or stay-at-home orders. In about 24% of the sample, the challenge was to a restriction on a religious activity or gathering. But challenges to vaccination mandates or certification requirements and mask mandates were also fairly common in this sample. Next slide, please. So what do we find? Let me highlight the 5 key takeaways from this study. The first was the fairly surprising finding that courts seem to reconceive of what constitutes an enactment or an order that burdens religious liberty. Of course, most of the COVID health orders that imposed restrictions on gatherings were not specific to churches or other religious institutions. They were broad. And under the pre-pandemic state of the law, those would have been analyzed as so-called neutral laws of general applicability. And that's important because it means that courts will apply their lowest level of scrutiny, give the highest level of deference to the officials that thought it was necessary to impose that order or law. Not so here. Now, even seemingly broad neutral laws will be considered laws that burden religion, and the consequence of that is that courts apply their highest level of scrutiny, and that's almost always fatal. In our sample, it was always fatal, of course, by definition. So what it means for public health officials going forward is that as a practical matter, they cannot restrict religious activities if they allow any secular activity that a court, not them, but a court would deem comparably risky to have greater liberty or latitude under the law. Religious activity has to be the most protected out of all activities. So that means things like carving out so-called essential businesses seem to be off the table in these jurisdictions. Relatedly, our second key finding was that the treatment of religious liberty really poses big challenges for vaccination law going forward, even outside of COVID-19. And these cases have been used already to challenge childhood vaccination mandates, whereas previously courts, again, were very deferential to the scheme that a state had adopted in terms of vaccination requirements. Now it is no longer clear, as we thought it was before the pandemic, that as a constitutional matter, you don't have to offer a religious exemption. That's been destabilized, it's unclear. And it's also increasingly apparent that if you're going to offer an individualized exemption process, for example, medical exemptions, the courts are going to review the reasons for denying those exemptions very carefully. And in particular, we were surprised to find that even in settings like the military, which has historically been afforded all of this discretion to do the things that it thinks appropriate for its service members, the courts have refused to accept general reasons for denying service members' requests to get out of vaccination. Things like military readiness, a healthy workforce, in these cases were not sufficient. That is new. And it's really hard to get around to find an individualized reason to deny an exemption request that doesn't relate to those more general interests. Our third major finding has to do with the powers of agencies. Our judgment is that even though the statutes that these courts were interpreted would have supported a quite expansive interpretation of what agencies could do, these courts took the opposite approach, applying something called the major questions doctrine, which says that when a statute speaks to a matter of great social, political, or economic significance, Congress must speak with exquisite clarity in giving powers to administrative agencies. Courts are not going to allow agencies to interpret their way to novel exercises of power that aren't clearly spelled out. And in these cases, even things like ordering people to wear masks on a bus was deemed to involve a major question. And so again, what that means is that agencies are really hamstrung if Congress hasn't spoken to the exact situation at hand. These courts have struck down their ability to act in that area. And so the long game for public health, we argue, is to take the major public health statutes that have authorized federal and state agencies to act and rewrite them to make them clear about what the legislature does and does not intend. Next slide. Our fourth major finding is that there is now precedent for challenging health orders as so-called rules. And the legal implication of this is that when something's a rule and not merely an order, it has to adhere to all of these procedural requirements for rulemaking that are set down in federal and state regulations. Very detailed procedures, including lengthy notice and comment periods in some cases. This matters going forward, of course, because except in very short-term emergency situations, we expect that officials are increasingly going to be required to engage in these lengthy processes in order to adopt more lasting rules. And that going forward, while courts may accept in the short term a good cause exception to this rule, they won't accept it if the emergency wears on. So officials need to proceed to these quite cumbersome rulemaking procedures relatively soon. And finally, we found that in these decisions, a through line was courts really obsessing about the reasons that officials had given or not given for the actions that they took. They hammered away on the lack of explanation, the lack of evidence cited for the particular kinds of orders entered, often forgetting that early in the pandemic, there was considerable scientific uncertainty. So they asked questions like, why is 6-foot social distancing required for elementary school children, but 3 feet's okay for high school kids? These kinds of questions often have good answers, and we argue in the paper that officials need to be prepared to state them. It's not going to be enough to just assert in a kind of conclusory fashion that a particular order is necessary. And this is probably a positive development. So to end there, the one sort of silver lining is the courts sort of forcing officials to be transparent about the basis for their decisions and to revisit that basis over time, in addition to helping them defend against what we think will be inevitable litigation next time around. It'll help build public trust to prevent that litigation in the first place. Thank you.
Thank you, Michelle. And we'll finally move in this panel to Katelyn Long.
Great, thank you so much. All right, first slide. Well, thank you. It's an honor to be here and to be the last speaker on this opening session. Actually, we can go back one slide. I just wanted to put the names of all my many co-authors on the opening slide. This was a group project, and many of the people involved in our paper on spirituality as a determinant of health have really been leading the field for decades. So an honor to be accepted, to write together. And I especially want to thank our senior author, Dr. Howard Koh, for his leadership on this paper and seeing it all the way through. Next slide. So in our paper, we really take part 2 of a project we started many years ago under the leadership of Dr. Tracy Balboni, which reviewed all of the existing empirical evidence on the relationship between spirituality and health, and did so through a systematic review published in JAMA a few years ago, but not just bringing all that evidence together, bringing it to a Delphi panel to say, what are the evidence-based statements we can make based on the strength of the strongest, most rigorous studies to date? And the Delphi panel recommendations are in the 4 quadrants before you. This paper takes up those recommendations and asks how they are being implemented currently and how we might learn from these lessons to scale as we explore the future of public health. So the 4 recommendations that we explored are the following. First is to recognize spirituality as a social factor in health. And I think the last presentation illustrates that there are spiritual and religious forces in our society, and there is a big factor in the way they affect human health and well-being. Second is to use evidence-based approaches to spirituality and health. There's a lot we can learn. Third is to provide spiritual care and education for health professionals. And fourth is to provide spiritual care and support within health systems. We can go to the next slide. So for each of those 4 quadrants, we went through and looked at federal, state, and local level policies, organizations, practices to try to highlight folks who were actually acting out these recommendations, what we could learn from them. So at the level of recognizing spirituality as a social factor in health, we looked at something like the White House Office of Faith-Based and Neighborhood Partnerships that was actually started in 2001 and has continued through 4 diverse presidential administrations, and has really acted as a convening body, so to speak, bringing together faith leaders in the faith sector in conversation with government around topics that pertain to health and well-being to see what can be mutually acted upon from those unique vantage points. In the second quadrant of approaching action through evidence-based approaches, we highlight several examples of health systems and congregational health networks who have worked together towards the common good of the public's health. Things like using the assets from faith-based congregations, the many, many volunteers, health navigators, lay ministers who can be aware and alerted to when members of the congregation are hospitalized, and then come and accompany that person in their inpatient journey and then also in their recovery process, such that it would reduce the burden of care on the health facility, even save costs. So we highlight a number of really wonderful examples in Memphis and North Carolina and other places that are important to learn from. The third is providing spiritual education for health professionals. There are some wonderful existing resources, centers that have been dedicated to giving health providers from all different backgrounds training on these topics, how to approach this topic with patients. We serve a diverse and pluralistic society. There has to be some training with how you even bring this up, and then training with what you do when you find out that a person's spiritual life or their spiritual questions are at play, particularly at the end of life. So teaching people how to ask those questions, how to attend to that person in a meaningful way. These resources exist. And there's also a number of courses that have been underway at schools of public health that introduce the empirical evidence related to spirituality and health, and also highlight the way that faith groups are active in health in a number of ways. Finally, with spiritual care and support within health systems, we highlight the important role of chaplaincy across U.S. Health systems, but also some innovations taking place at places like the VA around common coding systems so that chaplaincy can be more integrated into clinical care, and other provisions through CMS that would provide spiritual care and chaplaincy support during palliative care and at the end of life. Next slide. So again, many more examples in the body of our paper if this is an area of interest, but you really couldn't get 13 people together thinking about this without having a part 2 of the paper, which is our own recommendations for how we can learn from these existing examples and build towards the future. So here we have 5 that we would put forward. The first is fostering spiritual and religious literacy during the training process, public health and medical training. You could start with 1 lecture, just introducing the empirical evidence related to spirituality and health, and just putting this in the consciousness of our next generation of public health professionals and healthcare providers. The second is around the idea of relationships and common goals. If you are the leader of a health department or a local health system and you don't know your local faith leaders, we would suggest that it's time to make some lunch dates and get to know your local context, your local community, with no agenda, only to get to know these folks, understand who they are, the communities they serve, the needs that they have. These relationships, we believe, can really be about rebuilding trust, fostering new forms of trust. And we would encourage not coming at it thinking that we're all going to share values here. We will not. But if we can identify common goals, it is a pathway for working together, for rebuilding trust, and for advancing the public's health in new and innovative ways. Third, we would say that attention is needed on payment issues. If we call for more chaplains, if we call for more provision of spiritual care, but we aren't thinking about reimbursement, then we're not going to go very far. So these are critical components to scale, both in healthcare settings and at the community level. Fourth, coordination and research, moving beyond roundtable discussions to more sophisticated partnerships between faith-based health providers, say, local government leaders, for how we can understand impact and evidence. And finally, dedicated funding. We're heartened to see new efforts in places like the National Institute of Health, Minority Health, and Health Disparities putting forward this topic as a roadmap for the future, and we hope to see more of that. So thank you for your time.
Thank you, Katelyn. Thanks to all of you for concise and informative presentations. We do have a little time for discussion here, and I got some nice questions from the audience as well as some of my own. Let me just begin with a broader sort of conceptual question. The last panel we will have is about community, and you all will be done and off the stage by then. So I want to ask you now a question that I think will be very much on people's minds by the end of the program. Whenever we have an agenda for reform, an agenda for change, an agenda for investment. There's who's going to get it done. And the more we centralize, the more we can sort of have an affirmative agenda. Decentralization is slower, it's harder, it's messy. Michelle, even your comments about the courts, a lot of that is sort of a decentralization issue, little jurisdictions here and there trying to set rules. So I wonder if any of you could comment on the tension between sort of a national and top level leadership around the direction of public health relative to local direction and engagement. It's a fairly open-ended question, but I'd love to hear some thoughts about it.
Well, John, I'll lead off. I mean, in our paper, Ross, and I do give attention to the need for community participation. We talk about the participatory budget modeling, and in our current system, again in quotes, local is critical, and certainly in terms of communications, addressing what public health does at levels ranging from local to national. Every player needs to be engaged, or change is not going to come. And I certainly would say that, but the state I know best at the moment around public health, Colorado, something top down is just simply not going to succeed across 56 different public health jurisdictions.
Well, I can speak to the legal infrastructure. We have a federal system of government, and by constitutional design, most responsibility for public health matters rests with the states, not the national government. Is that an ideal design for managing pandemics or other emergencies that are not local? Of course not. There's certainly more that Congress could do to expand the federal presence in this area. At the same time, what we've just been through should make us think really hard about centralization. For all of its downsides and the resulting inequity in the patchwork of responses to emergencies and public health laws generally, state action is a backstop when the federal government fails us, as I believe it did in the early months of the pandemic. Can we imagine a counterfactual in which governors had not had the power to declare emergencies on their own, to institute stay-at-home orders on their own, and this was federal power? It's a really dark conception of an alternate past. So I think at the same time that we recognize the limitations of this federal design, we have to acknowledge that in many ways it can save us, it just saves us unequally.
Yeah, I echo this concept that it's a yes and, so we need both at the federal and national, state and local level engagement and work for an overarching understanding of what the guardrails are. But as my colleagues are talking about, during the pandemic, one of the most important things we learned is that we have to have user involvement in design, right? So whether that's at the federal level or at the local level, it's the individuals, the residents who we're serving who best understand what interventions and what programming will improve their health. And, we were pushed to that in COVID, where we had these hyper local campaigns that were incredibly impactful and should serve as a model for how we go forward.
Yeah, I'll just chime in and say that I think there has been a disruption of trust. Well, there's two categories I'm talking about. There's faith communities themselves, and then there's a lot of folks who consider themselves spiritual and not religious, for whom the spiritual life is just an important part of how they conceive of health and whole person health. And folks in both of those categories had a number of needs that emerged during the pandemic, some of which felt overlooked or misunderstood. And I would say that now is the perfect time to engage in that slow rebuilding of trust. I think a lot of things felt from the perspective of religious communities put on them without the kind of backstop of relationship that would help understand or interpret, or even just understand that we were in some ways operating in the fog in early days. And so those kinds of relational context that would allow for those conversations to happen, saying we're doing our best, public health professional to local faith leader, we're doing our best. We're not sure we're getting it right, but we're operating in a sense that would protect the most amount of people based on what we understand today. Having the framework to even have those conversations, I think, would have changed the situation in a lot of local contexts. And would it have gotten rid of all adversarial relationships? No, but I think it could have made a really meaningful contribution to the way we experienced COVID.
Thank you for those thoughtful responses. Let me move in a slightly different direction. The healthcare system is having a resurgence of interest in social context, social determinants of health. It's not a new concept by a long stretch, but it's certainly has gotten more attention in recent years. Public health has always been tied to social context, and much of what people talk about is needed in healthcare generally is the integration of some public health and health system, how they work together. So my question to you all is, are there lessons from either side for the other, if I can put it that way, that are helpful here? Can public health learn something from healthcare systems? Can healthcare systems learn something from public health about effective engagement with the so-called social determinants of health? And I think, Katelyn, your paper, in some sense, you reference spirituality as a social determinant of health. So that's sort of a starting point, maybe, for the question.
I mean, I can kick off and just say that I think the advocacy around spirituality being included as a social determinant of health has really come from many public health scholars who see the work of faith-based organizations operating in health, or the way that spirituality, particularly religious community participation, has relationship to various outcomes for health and well-being. But interestingly, I think health systems at times are more sophisticated in that integration because chaplains have been so included so regularly and so frequently within health systems. So I think there's actual real opportunity for cross-learning. I think in health systems, there's been more thinking around accreditation, structure, the right role at the right time for when and how spiritual care can be a part of a patient's care experience, particularly when the patient asks for it. And so I think public health can learn from health systems in that way, and then health systems can start thinking more broadly about how it engages whole person health, the social determinants of health, and assets outside of health facilities that might actually help patients when they're entering and exiting care.
I'll comment a little bit. I mean, it's unfortunate that, Alan, that you have to use the word side, in fact, because we should be
It
one.
is, isn't it? Yes.
And, and harkening back to my clinical days when I was at the University of New Mexico, we had a lot of initiatives to try and build what we called social medicine into the curriculum, whether at the undergraduate medical level, postgraduate, with very mixed success. So these are not new problems. And I wonder if there aren't ways to assure that on the clinical side, we get better information, whether it's gleaned out of records by artificial intelligence tools or other ways, about what we know about the social determinants of health when the healthcare system is dealing with individuals. I do think the pandemic, highlighted the fact that there are sides. And, we had difficulty in dealing with getting the data from our clinical colleagues that we needed on the public health side. And I'm sure the frustrations cross back and forth, at least as we work through things in Colorado. So, I agree. And certainly with who got sick and who got sickest during the pandemic, social determinants of health were just right there and obvious and critical for both patient care and for thinking about public health interventions.
Yeah, I'll say that having lived deeply both in our public health and our healthcare systems in the US, it really is a continuum. So from an individual's point of view, whether they're trying to stay healthy in their community and take care of their families, and at times may need, because of their disease, to engage with the healthcare system or to do some preventative care. To them, it's all the same, right? That more of a continuum for the individual because they see it that way. And they are engaging with our systems that way. And we have set up these false walls between us. I will say that the pandemic showed us that when we need to, we can and did come together as one unit to make sure that services were available in the community. People knew where to go back. Things like housing needs were understood, nutrition needs were understood, how many beds we had at any given healthcare facility was understood. So we can do this. And we should be able to look at those examples to say, how can we make progress in that way of looking at it as one streamlined system, as opposed to these independent silos of care?
Michelle, I don't know if you want to. No
Nothing
need.
to add. That was
Okay.
beautifully put.
So this may be the last question we have time for. I think all of us are chastened a bit. John, you began with your slide with all the prior reports on reinventing and reimagining and the future of. And what everyone always says when they do a report is we don't want this report to just sit on a shelf. And actually, I think, to be fair, although this is certainly not the first effort, a lot of those reports did not just sit on a shelf. A lot of them had made quite a difference. So this is not meant to suggest that that's their fate. But I do think there is some exhaustion and a sense of, are we here again, and what will make this time different? So I guess I want to ask each of you. I know the issue just came out, so you haven't. I doubt you've all read all the papers like I've had the chance to do. But how do we embrace this moment? Your panel is really about thinking broadly about powers and roles and authorities and structures. How do we take advantage of this moment beyond the specific recommendations that each of you had? How do we think more holistically about using this opportunity to try to address some of these challenges we face? Love to hear from each of you in whatever order you'd like.
Well, one thing I've spent a bit of time thinking about in concert with Larry Gostin from Georgetown is the emotional, psychological dynamics that led people to bring lawsuits challenging health orders. In some cases, it's sort of straight economics. Their business was closed, they needed money, et cetera. But I do think that there is more to it than that for a lot of people, and that what we should take away from the fact of all of this suing is that people really felt voiceless in the management of the emergency. And that's very much related, I think, to the way our public health laws set up emergency response, that for a very long time, it is really up to just one or two individuals often to make these really hard calls. And where that individual is a health officer, they have a very specific mission, and the mission is, it involves balancing health against other values, but not to the extent that a legislator, for example, or a governor might think about balancing values. So I understand why people felt like there were not adequate accountability mechanisms or avenues for voice and influence in the process. And I think that's what we can take away going forward as we think about legal reform, or even in the absence of legal requirements for those things, engaging communities more in cultivating a shared sense of mission around emergency planning and response.
Thank you. Other thoughts?
Well, I'll comment. I mean, I think if you sort of put on your dissemination implementation hat here, there's a lot of work to be done, which would come with the question of who's going to do it, and will our professional organizations, our public health agencies, follow up? I mean, I think the dissemination steps are critical. I mean, realistically, doing all the work that we could do on our data systems is going to require funding from somebody. And it's not going to happen, certainly at the local level, without an infusion of funds and guidance on what to do. So I think we look at sort of the 7 topics that Ross and I have in the paper. Each one needs a different constituency to take it on and has different needs in a sense. And if, one thing that we can take action on, and of the interest in Monica's thoughts, is modernizing data systems and tools. How do we do that? There's one particular thing that is urgent, I think, in a sense. And if we're going to be, quote, ready for the next pandemic, that's where I think some solid planning and influencing hopefully would make a difference.
Yeah, I think to touch on that, in this issue, I think this issue of health affairs really is a playbook in a ways of how to move forward, because there are really concrete examples of cross-sector work, healthcare, public health, looking at the expanded dimensions of what is public health, how do we define it, and what are the legal ramifications, the spiritual, how do we use data and these new tools differently, and how do we lead with equity? And there are concrete examples of how to move forward. So I see it as different parts and ways for us to move forward. I think importantly, specific to the data piece of it, is that within what we need to do as public health as a nation is twofold in my eyes. Number one is to strengthen, as Jonathan, you were alluding to, our data infrastructure capabilities and capacities to go cross-sector, so we can do some of the work that we were addressing in the last question you asked, and then to use these tools of AI and Gen AI and say, for these tools to move forward in health, they will need leadership from us to say, how do we infuse them with an equity first approach? There is a way to do, in fact, we've written up an approach to health equity and a playbook of how to move forward with an equity-led approach to Gen AI that's based on public health principles. How do we think about these tools and engaging with them in ways that can improve public health? Because we need extenders and abilities to do this work in new and creative ways. And that, many times when I feel hopeless, I look to what did work in the pandemic and say, how can we take those and scale those and find ways to bring those opportunities into other dimensions beyond the ways in which we use them in the pandemic?
Great, thank you. Katelyn, I'll give you the last word.
Yeah, I'll just chime in and say, I think we need to heal a little bit. I think there's some, like Michelle was saying, there's an emotional and psychological aspect to what brought about litigation, what has led to increased polarization. And I think, from our work, one opportunity is to look at empirical evidence that we use every day and see that religion and spirituality, spiritual practices actually have a positive and can have a positive valence in how they impact human health and well-being. And including that as a part of the conversation makes that relationship between public health and religion, or public health and spirituality, less adversarial. It can admit and give ground to say, we see that there's also good that happens in these spaces. We see that there are assets that we don't want to overlook. And we also can own, I'm speaking as public health, we can also own that we might not have gotten that right in the last round, and help us understand how to do better next time. That is never a bad question to ask. Actually going straight to the places of greatest tension and asking, how could we do this better with you next time? Because we can have all the generative AI we want, but if people don't trust it and they don't trust the leadership deploying it, it will have a greater breakdown next time than we did this last time. So I don't actually mean this as kind of like a soft and fluffy thing. I mean it is profoundly pragmatic, that we can look at the empirical public health evidence and say, these things have value. They really deeply matter in people's lives. And we want to be learners in that process to rebuild these relationships and do it differently, do it better next time, do it more creatively, and frankly, do it with a little more hope than maybe we feel in our current moment.
Well, I thank you all for your excellent papers, your wonderful presentations that captured them so nicely. It was great having a conversation with you as well about these very important topics. So thanks to all of you. Unfortunately, we have to keep moving, so I'm going to invite our next panel. This panel is going to focus on issues around the public health workforce. You'll be hearing from Valerie Yeager, Professor of Health Policy and Management at Indiana University Richard Fairbanks School of Public Health. You'll hear from Allison Chamberlain, Associate Professor at the Rollins School of Public Health at Emory University, and from Chelsey Kirkland, researcher at the Center for Public Health Systems at the University of Minnesota School of Public Health. All of them have papers that address different dimensions of issues around the workforce. Valerie, I'll turn to you first.
Thank you so much. I'm happy to be here and to present on behalf of myself and my co-author, Heather Krasna at Columbia. Our study, When Money is Not Enough, Reimagining Public Health Requires Systematic Solutions to Hiring Barriers, discusses the ongoing governmental public health recruitment challenges, and it makes recommendations for change. Next slide. Given that the public health workforce is the central component of the public health infrastructure, it's problematic that governmental public health agencies have experienced workforce shortages for decades. These issues are attributed to insufficient and inconsistent funding, a dearth of people with public health training, a lack of visibility for public health careers, and a very lengthy hiring process. And while progress has been made towards some of these issues over the last decade, such as substantial increases in graduates of public health programs, a recent study estimated that the U.S. health departments need another 80,000 workers to ensure the provision of foundational public health services. In that context, hiring barriers are particularly important. However, next slide, please. Recent research shows that health departments, even when they specifically receive funding to recruit new employees, they still struggle to hire. Qualitative work that I've conducted and that my co-author Heather Krasna has also conducted has found that hiring managers report challenges in overcoming civil service and merit system related hiring barriers. These types of barriers include delays in establishing a position for advertisement, vague and confusing application requirements, as well as antiquated systems for applying and a lack of communication during the application process, long waits for civil service exams and scoring, hiring list requirements that create additional layers of bureaucracy and typically result in limited lists of individuals that can be interviewed for a position, and then ultimately comparatively low salaries, all of which create challenges in the successful recruitment of new staff. In our commentary, we synthesize the current public health workforce environment, including burnout due to ongoing workforce shortages that began well before the pandemic. We discuss how failed recruitments compound this burnout and stress, and then describe the civil service and merit system recruitment challenges in depth and discuss salary disparities that have been documented in recent research conducted by other public health systems and services colleagues, as well as my co-author, Heather Krasna. In sum, next slide, please. The public health system cannot be reimagined without the staff to perform the work, yet this is a problem that has seen decades of suggestions. Given the cyclical nature of public health funding, both budget-related and non-budget-related hiring barriers must be addressed if governmental public health is to close workforce gaps. Next slide, please. Our article provides a number of recommendations for change. These are summarized here, but essentially they include reviewing the hiring process from start to finish, identifying where improvements can be made, and implementing standard performance metrics to track how the system is functioning. Some of this is going on now with the public health infrastructure grant work, but it should be conducted system-wide across different agencies and across different settings. Considering workarounds to decentralize some control of the hiring process and reduce some of the delays, especially in posting vacancies, reviewing applications, and so on, if that's applicable. Facilitate the conversion of contractors, fellows, and interns to permanent hires, having already shown their dedication to the work and their performance. Having an ability to fast track them through a hiring process may be helpful for addressing some of the delays. Modernizing the recruitment technology and marketing to improve the candidate experience using applicant tracking systems and ensuring communication with candidates along the way. And lastly, conducting routine market comparisons to ensure competitive salaries, and offer incentives such as tuition remission and student loan repayment programs. Next slide. Numerous opportunities exist for reforming the public health system to address these ongoing hiring barriers. Making it easier for health departments to hire essential professionals may be one of the most effective ways to improve the health of our nation. And our article gives attention to this issue, which is important for supporting our agencies. Thank you.
Thank you very much. Turn next to Allison Chamberlain.
Excellent. Well, thank you so much for inviting me to present today. I'm super excited to be here. I'll say that when the issue announcement came out, I got very excited about this and thought if I could make my first paper on our fellowship program be a part of this, I'd be super excited. And I'm very excited to be here today. This program has been a delight to start and to evaluate and to improve over time. And so I'm happy to be able to share it with others. So I'm Allison Chamberlain. I am an associate professor in the Department of Epidemiology in the Rollins School of Public Health at Emory University in Atlanta. And I'll be talking about the success of the Rollins Epi Fellows Program in rebuilding Georgia's epidemiologic workforce. Next slide. So what our program is a 2-year service learning opportunity for early career MPH level early career professionals that have an interest in wanting to get exposure and experience in state and local public health in Georgia. And our mission is to enhance Georgia's state and local public health programs by training exceptional epidemiologists to passionately serve their communities and hopefully get excited about state and local public health and stay in this line of service for longer than just the fellowship. We hire in cohorts, and to date, we have hired 4 cohorts so far, and we're about to welcome our 5th come August of this year. So we started this program at the height of the COVID-19 pandemic in 2020, but when we started it, we had our sights set on its sustainability beyond the pandemic. As was experienced across the country in many states, the epi workforce at the time of the pandemic was insufficient to combat COVID-19. And as academics, we had an unprecedented opportunity during that period to assist. A lot of academic activity slowed, research, hiring, and we had the desire to, jump into the fire with our practice colleagues to really help out. Other regional partners, too, had an interest in engaging. That included foundations and philanthropies, and we leveraged these different factors to help us launch this program. Our dual goals from the outset with this program were to infuse that capacity immediately, but mentor for keeps. So as academics, we have, a long history of preparing people for professional occupations after they graduate, and mentorship is a big part of what we do. So we wanted to help out in that regard as much as possible and leverage academia to mentor these early career professionals as much as we could. So what has our program contributed since 2020? So we have hired so far 50 fellows in the first 4 cohorts of the program. They've been placed in 16 of Georgia's 18 health districts and at the state health department. Our in-program retention, meaning the number of fellows that stay the duration of the 2 years, is 87%, and that number's the same as we move into the graduation of our 3rd cohort right now. 50% of our graduation eligible fellows accepted first jobs after the fellowship program in Georgia-based public health practice. Others went on to public health practice positions in states around Georgia, as well as CDC and some terminal degree. Some folks went on to medical school and some terminal degree programs. Fellows and fellowship alums comprise about 1/3 of MPH level epidemiologists practicing in district level epi divisions in Georgia right now. So these last 2 bullets really illustrate how helpful this program has become in reinvigorating the epidemiologic workforce in Georgia. So in my paper, I try to talk about this concept of this fellowship program, and I term it an academically anchored pathway program. And I wanted to share a little bit with you all today about the facets of it that make it a promising approach to workforce rejuvenation, especially in that really important middle tier of hire. So those folks that kind of sit between division leadership and the earliest career hires like PHAP interns or Public Health AmeriCorps folks. These are the people that can serve that really important interim for people who are really early career. This type of model helps academically acclimated recent grads make a smoother transition to the academic culture they might be used to into the public health practice culture. It also leverages academia's hiring systems and benefits that kind of get at some of the things that Valerie just mentioned as being barriers to hiring directly. It provides a low commitment way of developing a new practitioner. You know, if this doesn't work out for a fellow or for a site, there's no commitment beyond the 2 years. But if you land on someone who's fantastic, it gives sort of a runway for the district or the site to onboard that person. It also keeps academia in touch with practice workforce need, which is something that accreditation bodies and national professional associations like the Association of Schools and Programs of Public Health are really interested in. It sidesteps certain onerous governmental hiring hoops, provides valuable supplementary mentorship to fellows. So our program offers fellows academic mentors in addition to site supervisors. And it also, and most importantly, sustains and infuses, creativity at the outset of one's career and practice. Our workforce, our public health workforce has gone through the ringer in the past few years, and having some people coming in with a little bit of support on the creative side can really help, broaden what is possible in the years to come. Next slide. So I wanted to end with this picture. This is an image of one of our fellows from our first cohort. Her name is Ramona Barnett, and she was placed in the Macon Health District in Georgia. And this picture is of her presenting at last year's Georgia Public Health Association conference to a standing room only crowd on her presentation on informatics and data visualizations. She was hired on by Macon after she graduated our program as an informatics epidemiologist, and has really made tremendous contributions both to her district and to the state. And this particular session was so well received last year that it became part of a half-day workshop that occurred in May of this year prior to this year's Georgia Public Health Association conference. So I just want to end by saying I hope you all read my paper and enjoy it, because I think it's something that shows a lot about what can happen when you kind of connect academic schools and programs of public health directly with this need to infuse a better workforce into our system right now. But I didn't do this alone. I want to thank our co-authors, Shelby Rentmeester, who is the director of the program, and especially those are our Georgia Department of Public Health partners, Sherry Drenzik, Jessica Pavlik, and our health commissioner, Dr. Toomey. We had tremendous support from foundation partners to get this program off the ground and sustain it until now. But it really is a promising model that would be great to propagate in other areas of the country and other jurisdictions that have an interest in leveraging their academic partners for workforce solutions. Thank you.
Thank you. And now I'll turn to Chelsey Kirkland.
Thank you, Alan, and what a great segue. Allison, you mentioned Public Health AmeriCorps, and so it's a great segue into this final presentation of the panel. So thank you. I am Chelsey Kirkland, a researcher in the School of Public Health at the University of Minnesota, and I'm honored to present our article, Minnesota Public Health Corps, a new model for building the governmental public health workforce, on behalf of my co-authors, Henry Stabler, Jacqueline Frank, Alana Stimes, Peter Nelson, Ben Suker, Sarah Tumla, Craig Hedberg, Jonathan Leiter, and AJ Perlman. Next slide, please. Thank you. Governmental public health workforce is central to the United States public health workforce system and defense against population-level health threats. However, several key pieces are missing to provide adequate infrastructure and public health services. A recent statewide cost and capacity assessment indicated a need of at least 2,000 more full-time equivalent positions in Minnesota. Also, the current workforce is not as diverse as the population it serves, as only 14% of the current workforce is non-white, compared to 22% of Minnesotans being non-white. Lastly, younger generations are missing from the current workforce, as only 15% of the current workforce is younger than age 35, and across the entire United States, about 75% of those who are aged 35 and younger left their positions between 2017 and 2021. Next slide, please. Minnesota Public Health Corps, which is a Public Health AmeriCorps program, aims to fill these workforce gaps. This AmeriCorps program is a collaboration between the University of Minnesota School of Public Health, AMPACT, and Serve Minnesota. Public Health AmeriCorps is a joint initiative between the Centers for Disease Control and Prevention and AmeriCorps to create a service-to-career pathway. AmeriCorps members serve in public health settings, gain valuable experience, and receive support with the intent that they continue on into a public health career. As such, Public Health AmeriCorps leverages the expertise of both agencies, capitalizing on AmeriCorps' decades of experience managing innovative public health service programs in communities while benefiting from CDC's technical expertise as the country's leading public health agency. Minnesota Public Health Corps is the only Public Health AmeriCorps program focused on governmental public health. Next slide, please. Our article is the preliminary program evaluation for Minnesota Public Health Corps, which focused on two outcomes of interest. First, host site capacity to deliver public health services, and secondly, member skills and career development in public health. This preliminary evaluation was multi-leveled by collecting a range of process-oriented qualitative and quantitative data at both the site and member levels to understand how it was implemented in the first year. On this slide, you can see the various data collected at both the member and site levels. Next slide, please. Overall, during its first year, Minnesota Public Health Corps placed 66 members within 35 host sites. On the left are the age and racial demographics of Minnesota Public Health Corps members compared to the existing public health workforce on the right. As you can see, 62% of Minnesota Public Health Corps members were under the age 24 and 27% were aged 25 to 34. Though it is yet to be seen if these younger individuals will go into public health to fill in some of the missing pieces of the workforce, it is a promising start. When we compared the racial demographics of Minnesota Public Health Corps against the existing Minnesota Public Health workforce, 27% of members were non-white compared to only 14% of the existing workforce. We hope to increase the racial diversity of members in coming years, but this is progress. Next slide, please. Public Health AmeriCorps is designed as a service-to-career pathway. As a result, after year one, we found that 85% of host sites feel that the program prepares members for a public health career. Also, 79% of members intend to pursue a public health career. 12% of members have obtained employment. 24% of members are actively seeking employment. 30% of members are pursuing further education or training, and 14% of members are planning for an additional service term. Next slide, please. Lastly, increased capacity within public health, both immediately and long-term, has been crucial, especially in recovering from the COVID-19 pandemic. After the first year, members spent over 75,000 hours building capacity within health departments, which improved need capacity gaps. On the right, you see Exhibit 1 from the article. The teal bars show the average gap between capacity and need within host sites before service, and the orange bars show the average gap between capacity and need within host sites after service. These gaps were examined within 5 capacity building categories: COVID-19, community engagement and communications, internal process improvement, data analysis and interpretation, and data collection and planning. A positive gap indicates that the need is higher than capacity, and a negative gap indicates that the need is lower than capacity. For all of the categories except COVID-19, the before service gap was larger than the after service gap. And this decrease was statistically significant for community engagement and communications, data analysis and interpretation, and data collection and planning. These decreased gaps indicated improved ability for public health agencies to deliver public health services. Over time, Public Health AmeriCorps programs like Minnesota Public Health Corps aim to increase capacity within the public health system immediately and longer term by filling in missing puzzle pieces of the public health workforce, including increased workforce diversity, younger generations working within the workforce, and overall increased number of employees within the workforce. Thank you very much. My contact information is on the slide, and if you would like to learn any more information, please visit our sites. Thank you.
Thank you all for the papers and the presentation. I'm going to ask at first sort of the question that I can't help reading all three of the papers. The second two have a very positive story to tell about our ability to build the workforce. But the first paper says, maybe not so fast, we're struggling here. And my first question to all of you would be, what do we know about the ability to move from these sort of early career opportunities to actually longer term improvement in our ability to meet needs? It seems to me that we have very positive short-term stories out of the programs that were presented. Can we keep that going? What's it going to take to keep that going? That's really to any of you who want to take it.
Well, I'm impressed by the ability to hire the epidemiologists that were trained into the public health workforce in Georgia, making up a third of the epidemiologists serving in the public health setting now. That is really outstanding. I haven't read the paper, so I want to hear sort of what the process was like for their hiring, but creating these training programs is one way to bridge the gap between academia or some other practice setting that relates to public health and bringing people into the workforce. Sometimes these programs are low in salary, so they are also hard for some members of our population to be able to live on. So we want to make sure that they're providing enough funding, as these two programs have been able to do. And then we want to make sure that we can start the hiring process, which we don't have great data on our state and local public health hiring timelines. So time to hire and time to place people in a position isn't being tracked consistently. But the data we do have says an average of 204 or so days from posting a position to getting someone in it. If that's going on while someone is in a fellowship, then that's meaningful for them because they have a placement in that time period. But if that happens post-fellowship, people can't wait that long to start a job. So while our article seems a little dismal, it's really about let's shine some light on these challenges and begin the process of fixing them. Some of them may require legislative changes, but there are others that don't. And looking into the challenges is the first step. And I turn to others for their opinion.
I'll chime in too. So the neat part about our program is that the administration of the process of recruitment and screening and interviewing is primarily managed by our team at Emory. So we're able to leverage our HR to get our position descriptions for, well, first of all, we start with applications from districts or host sites around the state about whether or not they want a fellow in the next cohort, which usually starts about February. And then we're able to develop position descriptions for each of those opportunities that then get posted around the late March, early April. And then after that, as applications roll in, we begin doing screening interviews with folks that have applied. And we kind of batch the most promising candidates for the different sites that the candidates have applied to, so that they have sort of a curated group of top candidates to do the final interviews. So the site districts do the final interviews, so they have a hand in selecting, who they want in their environment and in their offices. That works out really well, takes a lot of the burden off of them, but has the final ultimate decision making in their hands. And that's worked really nicely. And so offers tend to go out sometime in mid-May to right about now. And then our fellows start the first week of August with a week-long orientation at Emory, and then they go to their host sites the second week of August. We've pulled a lot of inspiration from existing programs like CDC's EIS program, CSTE's Applied Epi Fellows program, other programs actually in Minnesota. We've done a lot of pulling the best from some of the other examples of this. I think the unique part of our program is, again, it's anchored in academia. Some of these other programs have other anchors, whether they're professional societies or federal government, state government, for instance. And so it's nice. Our, anchoring in academia offers a lot of benefits that, like we try our best to maintain a salary offer that is equitable, but also competitive. And it's a very fine needle to thread. But we want to try to, hire in folks that, have the capacity, have the interest, want to get in the field. Other benefits that the academic institution can provide are, access to libraries, health benefits, things that have to do with public health loan forgiveness, things like that are really wonderful kind of supplementary benefits to folks entering a program like this. And frankly, it's just so fun to run. It's fun to be part of seeing, not all of our fellows are Rollins graduates. Some of them are, but we're open to any masters of public health, recipient from an accredited school or program of public health. And it's fun to see them and support them as they enter their careers.
Chelsey, do you have thoughts on this?
Yeah, I was going to round out by saying one of the good things that we did notice is that the racial demographics of our program and of Public Health AmeriCorps were actually very strong. And so we often think of AmeriCorps as being limited and not everyone is able to participate. But that barrier is decreasing, which is great. Also, similar to Allison and how Public Health AmeriCorps is able to really help prepare members to go into the workforce. And so what Valerie was talking about of improving some of these hiring laws and barriers, while on the back end, some of these programs are continuing to help create that prepared workforce to step into those positions.
Well, we're short on time. I do want to say we got a bunch of questions right at the last minute from the audience. This is clearly a hot topic, asking the kinds of things you might expect. Sustainability, an important question. We just aren't going to have time for these, but I do want the audience to know important questions about whether people are actually ending up in state and county departments or they're going to other places, which is great for public health in general and for the people, but maybe not solving some of our workforce problems. But really a very high level of interest in this work. I have to ask in the 1 minute that we have left, did artificial intelligence get embedded in the curriculum for either of the programs at Emory or in Minnesota? I'm just curious, given the presentation we heard. Do either of you even know? I've just had to ask.
It was not in ours, but we are continually updating our own curriculum for our members. And we'll definitely take that back to our team to see, should that be included and how should that look?
Yeah, we have not directly yet. However, with this new cohort 5, we have 3 new fellows that are coming in as outbreak analytics fellows, and some of the AI might weave into what they do.
All right, just trying to foster some cross-panel discussion. Well, thank you all. It's nice to have some optimism about the future and the interplay between Valerie, your commentary, and these programs and what they can and cannot do. I did note that the title of your paper is about, it's not just about money, but there is a lot about money here too. So it's going to take a sustained effort, but it's nice to see some of that effort. And as I say, great audience interest in the workforce issue. So thank you all for this panel. I'm going to move us on to the next, just to keep us on track. We still have a lot of content to get to. The next panel is about sustainability and accountability within public health systems. You're going to hear from J. McCullough, Associate Professor at Boise State University School of Public and Population Health, and also Nir Menachemi, Interim Dean and Professor at the Richard M. Fairbanks School of Public Health. I do want to note that this panel initially also included a third paper on the topic out of Oregon. It was describing efforts to build a system of accountability metrics and use them. Matamala and colleagues, unfortunately, we had a last minute inability of the panelists to participate and couldn't get another one of the co-authors on, but I encourage our audience to look at that paper as well if you're interested in these topics. And with that, I'll turn it over to Mac.
Thank you very much. It's a pleasure to be here today and appreciate this theme issue. And I had the pleasure of working with colleagues from the University of Minnesota Center for Public Health Systems, Indiana University in Indianapolis, and also NACHO. And I'm delighted to share some of our findings here today. Next slide, please. So the previous panel just left off talking a lot about workforce and mentioning that there's some money involved in that. And I guess I'm sort of the inverse of that, talking a lot about money, but because there's a huge workforce component to that. So we sort of picked up on this study where the American Rescue Plan and some of the funding that went into public health from that opportunity left us, which is we have some investments now into public health. We've had gaps and shortages for quite some time, but we'd really like to look under the hood a little bit to figure out sort of how funding is structured in local health departments, and if there's a way that we could sort of advance collective understanding of what that means and whether things are changing or remaining roughly the same. We use data from NACHO, National Association of County and City Health Officials, from their profile study, dating back through 2013 up through 2022, which we're excited to be able to incorporate in this analysis. That's the most recent peri or post-COVID data. So next slide, please. So what we were able to do with these data is create something that we call the Diversification Index. If you're familiar with how diversification is measured in other industries, it's very similar to that. It's based off the Hirschman-Herfindahl Index. The advantage of doing that is it sort of puts, it can help quantify something that a lot of us in public health have probably been feeling over the years related to revenue diversification. Sometimes we have a lot of funding from a lot of different sources. Sometimes we are very reliant on only a smaller number of sources. And it's helpful to have some way to quantify that so that we can track this across jurisdictions, across time, and see if this is associated with things that we would like it to be associated with. So we saw very little change in funding between 2016 and 2022. In general, health departments serving larger areas tended to have more revenue diversification, which in this context means a greater number of more equally sized funding sources versus a smaller number of funding sources that may be greater in magnitude. And less diversified health departments, so those departments that just have a fewer larger funding sources. Again, this is sort of the proportion of your funding portfolio. So if you think of it as a pie, we're not, in this context, we're not talking about the overall size of the pie. We're just talking about how many slices there are and how relatively equally they are distributed. Next slide, please. And so we'll go through this a little bit sequentially here. What if we click advance? One of the first things we noticed when we started looking at revenue diversification is if you click advance to get up the next animations here. Less revenue diversification was associated with a greater reliance on a single revenue source, specifically local. So the health departments that tended to have the lowest revenue diversification tended to have huge slices of their pie that came from local funding sources. Contrast that with the most well-diversified health departments. They tended to have a smaller proportion of their funding sources coming from local, but also they got a little bit more of their funding sources from federal and state sources, and also clinical sources. So part of this is what you'd expect based on how you calculate a diversification index. But also, if you look in terms of who's getting any funding whatsoever from these sources, well-diversified health departments also tended to just report, yeah, I get a little bit of money from them, even if it's not a lot, compared to not as well-diversified health departments. And then the main thing that sort of piqued our attention was this very thing, the thing at the top, that less revenue diversification was associated with lower mean per capita revenues. This is, bear with me here, because I'm either preaching to the choir in that you already know this and that you've lived this life, or I'm spitting a lot of jargon, and it maybe not connecting. But basically what we're seeing was this was not necessarily the case, that everybody has the same shaped pie and some just get a lot from local and some get a bunch of smaller sliced pies. This is not causal. This is an associative finding. However, we are seeing basically that the quartile one, that well-diversified health departments, they have larger pies that they're working with. And again, we need to do a little bit more work to figure out what exactly is the cause of that. However, this is promising, and it's helpful, I think, to have this quantified and also have this finding out there for future work to expand upon. So next slide. So our point with this paper, and especially with the title, was it's one thing for us to understand that we have funding and workforce gaps within the public health system. I think it's another thing, though, to start thinking about how we might want to consider working to close those. Meaning, is it okay if we just get one giant pot of money and dump it into the system? Would there be different benefits or different results from getting a couple different sources and mixing it all together? So we wanted to contribute to this area, one, by calling attention to it, but also by advancing how we think about it quantitatively and adding some sort of rigor to how we measure this type of thing. We also wanted to also point out that we are starting to see some of the nuanced ways in which this revenue diversification may have impacts on the public health system, just with the different funding sources that have come online in the past few years. And I think some of the reports from practitioners in the field in terms of how the funding sources are actually able to be used, to actually grow the workforce, actually provide new or stronger public health programs within your communities, are going to be really helpful when we can overlay work like this on top of it. So thank you very much for the opportunity, and delighted to be part of the panel today.
Thank you. And now over to you, Nir.
Thank you so much. Delighted to be here. As was said, Nir Menachemi from the Fairbanks School of Public Health at Indiana University in Indianapolis. And I'm excited really to be representing my co-authors listed here on the screen, each of which is a critical public health leader, not just in Indiana, but really beyond, and each of which played a key role in making Indiana's experience that's really memorialized in this commentary possible. So what was exactly the reason for this paper? Some of you might know that Indiana recently increased public health funding by an unprecedented 1,500% in 2023. And the reason this is remarkable, not only because of the percent increase, but also because we are a conservative state. And we did this significant increase in public health investment at a time when trust in public health, trust in government, and maybe even trust in science among some conservatives has been pretty low. And so how did Indiana do it is really, I think, what this commentary ultimately is focused upon. Next slide, please. Our story really began with what I'll call a prequel report. And this was a report that was published by, coincidentally, one of the speakers on the previous panel, my colleague, Dr. Valerie Yeager, and one of my co-authors, Dr. Paul Halverson, and several others from our Fairbanks School of Public Health. But in late 2020, we released this report, which was funded by a trusted local philanthropic organization, the Richard M. Fairbanks Foundation. And this report really found a couple of things here that are listed that a lot of stakeholders in our state, and I think this is true in many other states, are challenged to differentiate between the medical system and the public health system, which is focused on prevention. The report also highlighted the fact that Indiana communities tend to underfund public health. And as Mac actually just mentioned, also in Indiana tend to over-rely on local funds compared to norms across the country, which far more rely on state funds. We also basically cataloged the lack of essential public health services that are available to all citizens of the state, and really sort of highlighted significant deficiencies in service availability, public health services availability. And the report also tied a really nice, strong link between how not addressing these issues will likely stall some of the state's economic development goals. Next slide, please. So the last thing the report did is recommend that a task force be an inclusive task force be appointed to address some of the shortcomings. And so that's what our Governor Holcomb, did. Which had broad representation from lots of stakeholders from across the state, including from our Fairbanks School of Public Health. But it, of course, included business and health leaders, local officials, especially local elected officials, and it had two very strategically selected co-chairs, one of which was a former state senator with lots of experience with the budgetary process in Indiana. His name was Luke Kendley, and then one of which was a true expert in public health and had formerly served as the state's health commissioner, and that was Judy Monroe, who's currently the president of the CDC Foundation. And the commission had monthly public meetings and really embarked on a listening tour, encouraged business and civic partnerships, coordinated communications with the governor's office and legislators, and were ultimately tasked with proposing structural and operational interventions that might address some of the findings of that university report that we had. And of course, this all was supported very strongly by the Indiana Department of Health that included staff and experts from there. Next slide, please. I'm so pleased to share this picture, which really captures Public Health Day, which we describe in the manuscript, which was held during the legislative season here in Indiana in 2023. And you can see hundreds, if not thousands, of supporters that really came out in support of public health, in support of the health department, in support of the general work that the commission was doing. And it really generated this grassroots feel to the work that was being done and really demonstrated, I think, wide and large, how much support there was from all sorts of different stakeholder groups and individuals. Next slide, please. So at the end of the day, we kind of boiled down some of the lessons learned, and I'm going to kind of briefly chat about each of these. One of which was the importance of that locally authored report, which was commissioned by a trusted source, which was, I think, ultimately put out by trusted researchers in the state. But why it was so important is that it established a shared understanding. Many times when we engage in discourse, people might not all be on the same page and make different assumptions. And it made it very easy to advance the dialogue when everyone sort of started from the same page. Next animation, please. We also spent a lot of time, both in the original report and then in the work of the commission, to stress the link between the health of a population and future economic vitality. In fact, it was surprising how few intrinsically perceive this connection. Next bullet, please. The commission also did a lot to build up trust and be transparent, which I think is critical, not only for any government agency or body, but especially in the, I think, the divisive environment that we're in. The more trust that can be generated, I think the more we all benefit. Next bullet. And those two co-chairs with really complementary skills in both the political process and in public health and in engaging a broad range of stakeholders on the commission was critical. And the last bullet here, which I want to spend the last couple of moments that I have really focusing on, next bullet, please, was the deliberate attempt to decouple public health from partisan narratives. Very frequently, we talk about what's wrong with the system and focus kind of with a negative orientation on the past. In our experience, focusing on the positive future orientation of what a strong public health system could bring was far more fruitful. And so really appreciate being part of this, this panel and being part of this special issue.
Thanks to you both. And again, I remind the audience that there's a third paper on this topic that we hope you'll read in the issue as well. Let me just, we just have a couple of minutes for questions, but let me start with sort of the perennial public health challenge, which is that the boom-bust cycle that everyone ignores public health when things are going well, and so we stop investing in it, and then something happens and people realize, oh, we need a stronger system, and then the cycle just continues. I wonder, the victory in Indiana is substantial, but as I understand it, it was one budget cycle of 2 years, if I get that right. So I don't know if that's sustained. And obviously, the empirical work is descriptive, not more than that. But I am just curious whether either of you have insights into the ability of anyone to break out of this kind of boom bust approach that we so often see.
And Anna, let me just correct. The intention of the legislator was to increase the amount every 2 years. We are on a 2-year biennial budget. And so this was not a one-time thing. This was expected to recur. There's, of course, a lot of benchmarks and a lot of metrics that are in play, but this was not a one-time and done.
Okay, good. Good to know. Good to know. Additional thoughts, though, and is diversification potentially a way out of some of that cycle, or does it just exacerbate? In investing, you tend to think diversification gives you some protection, but I don't know if that works.
That was certainly one of our motivating theses as well. As when we think of other industries, right? When you think of your own portfolio of assets. In general, having a more diversified portfolio of revenues coming in can protect against some things like that. There's actually been some mixed evidence that has come out in the literature on whether or not that's the case for public health. However, this sort of offers us a first glance at how things are unfolding across the nation. We can then track better, not just in terms of total per capita spending, but also how the revenue portfolios change as funding interest ebbs and flows over the crisis cycle, as you're mentioning, Alan.
And I would add, while clearly governmental public health is an important piece, it shouldn't be the only piece of public health in society. And so to the extent that Mac's point about diversification also includes all the other investments in public health, including from the private sector and from individual communities and otherwise outside of the governmental sector, I think that's an important piece. We might have, as a nation, been underfunding public health in all areas, but we focus almost intensely, perhaps to a flaw, just on the governmental piece.
That's a fantastic point here, and there's almost a corollary to our analysis that's sort of the inverse of that. How do we fund health in a community, right? So that would include both healthcare and public health and social services and more. We did not do those analyses. I welcome, obviously, others to pick up that baton, but that's a really important way to think of it, right? Because at the end of the day, most likely we're interested in the health of a population, which includes both, which is determined by a lot of things, one of which is a public health system, and a lot of isn't.
No, that's excellent, and that ties, of course, to conversations we had earlier in the program about this. We always revert to this sort of division of public health and health services. Similarly, I think we think about public health as public sector investment, and if the more we can move away from some of those, that offers us some guidance. I did get a question from the audience, and you note this in the paper, so I know you can answer it, Nir, about the issues related to local and state and what is, and I think actually we can expand this, I think, Mac, to a question for you as well. But when we think about public health spending, there is also the allocation of resources across different levels of government. And so if you can speak specifically to how Indiana approached it, and maybe Mac, you can speak more broadly about that topic.
Yeah, thank you for the question. So in Indiana, the way ultimately this was decided, and this was based on significant input from local communities, especially at the county level. There's an opt-in approach to get the funding from each of the counties. And so counties get to decide whether or not they want to accept the dollars. And in exchange for accepting the dollars, the state basically just holds the local county responsible for the outcomes. It doesn't dictate how it has to go about it. Sometimes some counties might hire some folks, they might contract for, others in the area, or might partner with neighboring counties to get the work done. But why did we do it that way? I think in our state, there's just a history of just dynamics where that solution tended to work for us. Really, in our paper, we were trying to highlight the Indiana experience, not to show that it was esoteric or unique, but to say there's a lot of things that could be taken away and generalized elsewhere.
Agreed. Near, just to build off of that, I thought the takeaways, the 5 takeaway points were really instructive. I think hopefully that almost everyone here can take away something from at least one of those points, but I know I certainly could. And just to sort of build on that in terms of the funding, structures and where things are coming in, and zooming out even more to nationally at looking at all the NACHO data that are available, we did look at the type of governance systems and structures that are in place in a state. So, centralized versus decentralized state and local governance. And there were some differences across those. And again, this is associative, not causal. But one, I guess, relevant takeaway for practitioners might be, when you're comparing your diversification index, which we go through in our paper how to calculate. If you want to calculate your own, it's not too hard at all. Being sure to make the right comparisons, right? To not only to think about the structures and the funding mechanisms that are in place, and try to find other similar peers to think about when comparing, whether that's yourself over time or others right now.
Well, let me just close, Nir. I know you emphasized this as your last point around the avoiding the partisan language, and Mac, you're welcome to weigh in on this topic, although I think it's focused more on sort of the specific experience. I am curious how sustainable you think that is. We often go into these efforts trying to break the barriers down, and then something happens. You hit a point where, everyone goes into their corner. So you mentioned the critical role of your leaders. I just wonder how, and you mentioned that the funding is intended to continue, and an easy way for that to stop is if that kind of avoidance of the partisan narratives were to come to an end. So just from where you sit, I'd be interested in your sense of what it's going to take to sustain that kind of bipartisan support.
Yeah, and I hate to do this, but I want to turn the question on its side. I want to ask, what is the sustainability of the status quo, which isn't working, right? And so I think anything we do, we need to be thoughtful about how to make it last. So I appreciate the spirit of the question, but I would also argue that status quo is unsustainable. We can't keep being so inefficient with our limited resources. And, this whole idea of taking away, we're in just a milieu where certain words shut down the ability to engage in discourse. And so public health shouldn't be bipartisan. And I didn't mention this, but our bills were bipartisan. Public health should be apolitical. The partisanship should come in on how to achieve the goals of public health, not on whether we should. And I think it's unsustainable to make public health whether we should have the health of the population. We're far better suited in spending time on how we achieve that. And there might be legitimate disagreements. And so I hope that through sustained leadership in our state, we'll be able to keep the conversation on the right pieces. But admittedly, it's going to be a challenge for all of us to do that.
Okay, well, thank you both for your research on this and your presentations, handling a range of questions. To our audience, we do have one more panel. I assure you want to stick around for this. We're getting to a set of papers that look at a critical topic around the role of the community, and it's a broad range of papers looking at different dimensions of community engagement. So stick with us. It will be worth it, I assure you. As we bring our panelists up, let me tell you who you'll be hearing from. Alice Chen, former senior advisor for Made to Save Civic Nation. Sophia Simon Ortiz, organizing project director at Human Impact Partners. Ann Sossin, a lecturer at Dartmouth College. Ryan Petteway, Associate Professor at Oregon Health and Science University, Portland State University, who I think with confidence say is the only person I know who's published in Health Affairs both a peer-reviewed article and a poem. We'll hear from Carrie Cronin, Associate Professor in the Department of Social and Public Health at Ohio University, and Omid Hideri, Assistant Professor at the University of Washington School of Nursing. So as I mentioned, a broad range of papers covering the relationship to the community, and I'm looking forward to all they have to say. I'll turn first to Alice.
Thank you so much. Hi, everybody. It is so wonderful to be here with you all today, and I'm so excited to be with such an amazing panel that's working on connecting community and public health. So I do want to start by acknowledging my co-authors for this article, The Community as Full Partner, a New Model for Public Health. So I helped lead Made to Save, which is a national COVID-19 vaccine education and outreach campaign created by Civic Nation. And it focused on communities of color and supported a coalition of 1,600 organizations and 110 community-based organization grantees, several of whom are profiled in our article. Our next author is Denise Octavia Smith, who is a community health worker herself and the inaugural executive director of the National Association of Community Health Workers. Dr. Basola Ojikutu is the Commissioner of Health for Boston, where she has built innovative partnerships in Boston's communities to improve health and address health equity. And John Auerbach has been a leader in public health for 30 years, including leading intergovernmental and travel affairs at the CDC and as Commissioner of Health for Boston. I mention us all because we really tried to bring together the community and the public health perspectives in this piece. Next slide, please. So during the COVID-19 pandemic, when public health messaging got so distorted and lost amid misinformation, disinformation, and mistrust, many people in communities turned to community-based organizations that they knew and trusted for information and advice. And those community-based organizations took on that role incredibly. They demonstrated so much wisdom, creativity, and a degree of dedication and commitment that made a big difference for people in their communities. I just have some smattering of photos here, but there were organizations like the Black Boston COVID-19 Coalition that worked with the city to put mass vaccination sites in Black neighborhoods and staff them with community members. Organizations like Lupe put up tables and knocked on doors in colonias, these hot Texas sun, unincorporated border towns that didn't have a public health department, but they showed up. The Asian Community Development Council in Nevada partnered with a Thai temple to combine a vaccination event with a food fair in a place that people felt safe. The Navajo and Hopi Families COVID-19 Relief Fund created public health comics like the one you see here. It was in Navajo and it showed images that felt like home to people. And the Florida CHW Coalition created a COVID-19 infection prevention curriculum that trained hundreds of CHWs in English and in Spanish. Now, as we look at public health beyond the pandemic, many community-based organizations and community health workers have lost funding and lost attention. But if we want to really effectively address acute and chronic public health challenges, we have to make community a full partner in this work. Next slide, please. For this article, we conducted 2 surveys in November and December of 2023 to explore what are the barriers to strong partnerships between public health and communities. One survey was of large metropolitan health departments and the other was of community-based organizations. And bringing together those survey findings and our experience, we identified 3 main barriers. So number 1 was mistrust. So community mistrust of public health due to so many different factors, including past and present health disparities that have been unevenly addressed by public health. The second is siloed work and funding. Public health has traditionally been seen as the sole purview of the public health agency, rather than an all of society responsibility, which then we discovered during the pandemic. Additionally to that, many community-based organizations have faced administrative challenges in getting funding to do the public health work because it's been seen to be the purview of the department. And the third is insufficient shared decision-making. So we asked how communities are engaged in public health decision-making. And while many health departments and community-based organizations say community is invited to regular meetings with public health, only a small minority, these kind of top two bars up here, are involved in formal decision-making and policies and priorities or deciding funding allocations. Next slide, please. So in our article, we laid out 6 policy recommendations to address these barriers at the state, federal, state, local, tribal, and territorial levels. So number one is to establish community councils. So we recommend that the CDC and federal agencies should require state and local public health agencies to have community councils that have a formal role in public health decision-making. Number two, dedicated funding for community-based organizations. Community-based organizations have a hard time when they're competing with large institutions and health departments, so having dedicated funding can really help get more of that money to communities. Number three is funding that is not limited to a specific disease or condition. So diseases and conditions, the underlying reasons can be so multifactorial, and it is so important for communities to be able to have flexibility, to be able to meet local needs with local determination of priorities and programs. Number four is simplified procurement and reporting. So we recommend that public health agencies develop simplified processes that that lower the obstacles for smaller community-based organizations to get funding. Number five is technical assistance and training. While many grant programs do have kind of limited technical assistance programs, we recommend a centralized technical assistance program that helps build community-based organizations' capacity so that they can better sort of compete for grants and also complete the work. And then finally, bolstering community health workers and increasing diversity. So we know that we need increased diversity across the public health workforce so that we can better connect with our communities. And that includes sustained funding for community health worker employment, career advancement, and professional organizations. So all of these interventions, we believe, would help create the ecosystem and infrastructure that we need for community-based organizations and the community to become a full partner for public health. Thank you so much for your time.
Thank you for the presentation and the work. We'll turn next to Sophia Simon Ortiz.
Thank you so much. Can you all hear me okay? All right. Hi, everyone. I'm honored to present findings from a qualitative landscape assessment conducted to explore the nature and potential of partnerships between public health and community power building organizations to make tangible impacts on the social and structural determinants of health, and particularly in the context of advocacy. The majority of the authorship team, including myself, are staff at Human Impact Partners. We also had support from Frey Evaluation. And I want to thank our whole awesome authorship team, who I now wish I had photos of up here, but hopefully at a later date we can do that. Human Impact Partners is a national nonprofit focused on transforming the field of public health to really better center equity and to build cross-sector power with social justice movements. So community power has long been linked to health for decades in settings worldwide, but from our vantage point, we have long observed public health separation from community power building organizations, or CBPOs, as I'll refer to them. So even though these organizations, community power building organizations, share the health sector's goals of achieving health equity and racial justice, we often are not working together in an ongoing way. And again, it's really the shared goal of shifting conditions in communities to better support health. So to explore this gap and how to bridge it, in late 2023 and into early 2024, we conducted a national landscape scan, which included 35 community power building organizations and public health NGOs to understand what it would take for non-governmental public health to build relationships with and to provide advocacy support to community power building organizations and the wider social justice movements that they lead. So thanks. I see you've already gone to the next slide. That's great. So just some definitions to level set. First, on the left there, what is community power? This touchstone definition here comes from the Lead Local initiative, which is referenced in our article. And it really is the ability of communities most impacted by structural inequity to organize and act together to set agendas, shift public discourse, influence decision makers, and really ultimately change systems to advance health equity. And then on the right there, so then who are these CBPOs, the community power building organizations? So they're the entities most instrumental and really active in this work of building community power. They organize people into and are also accountable to a membership or base according to shared lived experiences. So that can be geography, demographics, and/or priority issues, such as people most impacted by housing injustices, workplace and economic issues, criminalization and targeting, as well as climate and environmental issues. So do these issues sound familiar? Yes, indeed. They are what we in public health have so long established as the social and structural determinants of health. These key aspects of communities' experiences that shape health and our material conditions. And so now a substantial collection of research, including pieces in health affairs, have established that community power is critical to this work and that it's both fundamental and instrumental to health. And what we mean by that is that it's fundamental in that just knowing that you have power to change things impacts your life, reduces stress, and we know the health implications of that. And it's instrumental in that power is necessary ultimately to change community conditions that affect health. And yet, public health practice approaches have not still adequately considered building community power as a strategy. And so our perspective is that health equity will not be achieved without building community power and also directly engaging in social determinants policy change directly. Next slide, please. So in that context, we wanted to explore the idea that meaningful public health partnerships with CBPOs are both possible and necessary. We aim to describe the opportunities as well as the barriers to alignment and collaboration across these sectors. So this was our approach. We conducted interviews and online research with representatives from 35 CBPOs and public health NGOs. And the focuses of the interviews were, we explored with CBPOs, we explored their understandings of their work's connection to public health, their interest in public health voices and advocacy tactics with them, their readiness and willingness to partner with public health, and also their willingness to advocate for public health as a field. With the public health organizations, we examined their capacity and willingness to partner with CBPOs, their use already of advocacy tactics, and their interest in potentially coordinating with public health organizations more around this work. And just to note, we focused explicitly on non-governmental public health institutions, or organizations, rather than including governmental entities because of the critical role that we see them playing in conducting advocacy work, given the limitations of governmental entities. Next slide, please. So getting into the key findings quickly, and I know we'll have more time to discuss these, so I'll go through. We found that by and large, public health still doesn't get power building overall. Many groups we spoke with were not deeply familiar with the efforts of CBPOs and national networks, even if they know that power imbalances ultimately are at the root cause of health inequities. Next. Many CBPOs understand their work as public health, but still do not actually always understand what the field of public health does. And as we heard many speakers name earlier, there's still this conflation of public health and healthcare often. But that the social determinants of health kind of framework really resonates with them, and they understand it as core to their work. Next. Many public health NGOs use many advocacy tactics, but are generally not in service of community organizing campaigns. They see themselves as able to provide data and research, but there's still some uneasiness among some in doing advocacy for these campaigns directly. Next. CBPOs, by and large, really value experiences with public health organizations that they have had and see the role of public health experts as validators of their members' lived experiences. And there's interest in deeper partnership, especially leveraging health frameworks, data, institutions, and voices across a broad range of advocacy work. And then lastly, we also asked this question about whether CBPOs would kind of go to bat for public health, given the threats and the attacks that we see also on our field. And there was general interest in this, but that CBPOs said they would need to really see the clear through lines to their work and the material changes that would also bring for their members. And then lastly, for real this time, Many public health organizations were interested in a more coordinated collaboration across our ecosystem around advocacy work and specifically supporting CBPOs. And then last slide, just quickly. So where are we going from here? We've actually already begun implementing some of these learnings across this work. We are sharing our learnings internally with the public health NGOs, mainly that participated in the interviews, and across the sector to understand, seed new thinking around advocacy. And we're working with nearly 24 of the most ready and willing public health NGOs to form a coordinated advocacy entity and perhaps a coalition, which we've now tentatively called the Public Health Solidarity Coalition, but that's to be determined and on the table. And so we are looking ongoing to close the advocacy gap that we see here again between our public health ecosystem, especially on the non-governmental side, and the CBPOs. Please contact us if you'd like to learn more. There's a lot more here, obviously, that we couldn't get to, and look forward to the rest of the discussion. Thank you.
Thank you very much. I'll now turn over to, go ahead, Ryan, if you don't mind.
Yeah, appreciate it. Yeah. Thanks for having me. Super excited to have our paper in this special issue on reimagining public health. Shout out to the squad here that helped co-write this and helped lead this work. Really excited to be able to share on our behalf. And I also point out that Kasuma Guatemala also has 2 papers in this collection, which is...
Yeah, sorry, I thought Ann was going first, but I see your slides up. So we'll sort this out. Go ahead, Ryan, if you don't mind.
Yeah, appreciate it. Yeah. Thanks for having me. Super excited to have our paper in this special issue on reimagining public health. Shout out to the squad here that helped co-write this and helped lead this work. Really excited to be able to share on our behalf. And I also point out that Kasuma Guatemala also has 2 papers in this collection, which is pretty amazing, pretty incredible. Now I can hear. Can y'all hear me now? Am I good now? Okay. Sorry. So quick background. This paper is a mix of critical essay and a brief summary of the work that we did in Oregon to improve survey modernization processes out here. So by way of quick background, public health surveillance and data systems in the US remain an unnamed facet of structural racism. Oftentimes we talk about addressing structural racism out there in the systems of power, economic systems, housing, land use, all these things. And we good? Okay. And we're so keen on gathering data about what's going on out there that we're not thinking about what we're doing for ourselves in here and how we're actually going about our research processes, right? We see the same thing in surveillance practice and processes. As we suggest, these systems that we are using to monitor and assess population health are protections and reproductions of political priority, epistemic privilege, and racialized state power. What gets measured, what doesn't get measured, who does the measuring, how much funding there is or is not to do certain measurements. There's a couple presentations about the funding structure of health departments. Public health is fundamentally political. So we want to talk about pursuing justice and health justice, and we're trying to be apolitical and ignoring the fact that there's a power structure that determines whether or not health departments have certain resources and opportunities to respond to and identify community needs. It's a losing battle from the very jump, right? And so what ends up happening, we see public health surveillance, is that we see these very status quo measures and metrics that are premised upon comparing various communities to each other, not actually producing knowledge and data that can be that people can take action on within a specific community and context. And they're also premised on this idea of trying to find harms and find damage and risk, because the idea is that if we can document more need here, then we can get more grant funding to address those needs. And so we're not leaving room for much else in the conversation by doing this, particularly when we talk about communities of color. Communities of color are more often than not portrayed as the most at-risk, quote unquote, vulnerable, or the darker risk spots on our map, right? That's all our data is capable of producing in terms of representing communities of color within these systems. And so, as we suggest that we must disrupt this and offer a new path forward to reimagine how these surveillance systems and these survey systems and processes can allow for a fuller story that allows a more humanized engagement and assessment of what's going on in communities of color to advance health justice. And so, quote here, we spent a lot of time talking about births just because it's the best example that we have for this in the US. And we talk about this idea of epistemic violence, this idea that because we are trying to find certain stories, we are essentially paying to ask certain questions, that we give the impression that this is the only form of knowledge, right? We take all the complexity that's going on in communities of color, and we ask this specific set of questions, so that all that's known about these communities is what we ask them. And it gives the illusion that that's all that exists in terms of the knowledge, right? We're not asking community members to speak for themselves about what's going on in their daily lives. And so we're essentially silencing them, right? We're quieting their testimony. Black feminist scholar Chrissy Dawson talks about this idea, and as we articulate in the paper, that the Birthfest survey ultimately amounts to 25 plus minutes of epistemic violence and silencing. It doesn't allow for communities to actually articulate their own stories, share their own knowledges. It's only there to extract something to maintain a certain status quo narrative. And unfortunately, a lot of health departments are almost required to participate in this process because the use of Birthfest is tied to other funding structures and data systems. So if they want to remain operable and have other contingent funding structures at their service, they're required to use Birthfest data for the reporting. Next slide, please. So what we did here in Oregon is we tried to come together. So we have public health academics, we have social work academics, we have folks from community organizations, and also state data scientists coming together to try to figure out how to modernize our survey practices out here, centering anti-racist and decolonial principles. This work started with multiple teams, Black, an African-American team, a Latinx team, an Indigenous team. The Black and Latinx teams kind of did their own thing on this, at the beginning, had such overlapping interest and concerns and questions and processes that they formed a joint work group, and then went about a participatory formative assessment, examining Birthfest structures and data that existed in Oregon, and also the student health survey. Part of what that looked like was bringing in existing instruments and questions and scales, and really just critiquing them, interrogating them, and seeing what's there, what's missing, and what narratives and stories are being told, or what could potentially be told with what's existing there, and the ways in which we think we could fill that in. This was particularly emphasized within the student health survey, where authors Dr. Roberta Hunt and Miriam Mosini worked with youth to reimagine those questions, even rework some of those questions to basically have the youth ask their decide what their actual priorities were, instead of having somebody else speaking for them and asking them the questions that they felt were not necessarily as germane or relevant to their lives. We detail the specifics of this formative process and 2 reports that are through the state health department, and also 2 community briefs. And so those are cited in the paper if you want the details for that. What we focused on in this particular paper was articulating the ways in which we were informed and guided our work through anti-racist practice and decolonial practices, particularly public health critical race practices, principle of voice, centering voices from the margins, intersectionality, also the idea of disciplinary self-critique. This paper, of course, is an example of disciplinary self-critique. I think part of the issue that we have in public health is that we are afraid to critique ourselves. We are implicated in this, and so the last thing we want to do is talk about how bad our papers are, or how terrible our research project went, or how the paper we published 10 years ago missed the mark and we're embarrassed about it, right? That's fine. We want to get better, right? And I think Birthfest right now is not doing what it needs to do. It's status quo. The previous speaker mentioned that public health should remain apolitical, and I think that's fundamentally incongruous with the idea of disrupting status quo. Health is fundamentally political. Birthfest is producing status quo data that is producing knowledge and information that is not actually conducive to pursuing action within the neighborhood communities where the people who are responding to the surveys live. That is not a process that's conducive to disrupting the status quo. We have to think about the ways in which our data system surveillance structures can actually be used to pursue health justice, right? The previous speaker, also, the one that just got on here, mentioned community power building organizations, right? What type of data can we be using to generate in public health that is conducive to actually building power on the ground where communities are experiencing the consequences of social injustice that get embodied as health injustice, right? For us, we felt like in order to do that, we had to disrupt the standard logics that are embedded within population health surveillance systems. And so disciplinary self-critique is one of those. Also moving away from the idea of extraction. Oftentimes the data that folks provide by responding to these surveys, the respondents don't have access to that. The public doesn't have access to that. You have to pay for access in many cases in many states. The idea that what is in there is taken as some form of truth or a portion of a truth, and so it's misrepresenting communities of color, and communities of color are not able to essentially articulate and speak for themselves or defend or counter whatever's put out there publicly about their communities, whether they're mapped or whether they're in a regression. And then also this idea that we need to suspend damage to their narratives that comes with decolonial feminist scholar Eve Tuck, that the title of BRFIS itself, for example, the Behavioral Risk Factor Surveillance Survey, right? We're so focused on risk that we are incapable of seeing anything other in communities, and especially communities of color, that doesn't have to do with harm and damage and risk. There's no room for joy. There's no room for love. There's no room for resistance. Our survey instruments leave no room for anything other than finding out what's wrong. It's pathologizing and it's stigmatizing. Next slide, please. So, wrapping up here, going forward, what we suggest from our analysis and from our work is that we need to think about ways, there's a lot of communication and speakers talking about the public health workforce. What we suggest is that the workforce needs fundamentally different training to be more capable of enacting surveillance and data systems that are anti-racist and decolonial. So thinking about the ways in which we can change core competencies and foundational competencies for public health accreditation and MPH programs, certification programs, and positionality statements for folks that are working for state and local health departments that are working on data systems, right? So that they're more informed about the stories they're telling or not telling. And thinking about accreditation requirements potentially for local health departments. And then moving towards more community-led controlled data systems, decolonizing data hubs was something we outlined in our papers that we have written. And then, of course, leaving room for something other than risk and damage and harm, right? And so moving towards this idea of what Sinead Birch refers to as helpful narratives. Can we do survey work and practices that allow us to tell stories that are about healing and joy and resistance as well, alongside of trying to find the more negative health outcomes so we can compare and populations and address those as well. And I believe I'm probably at time.
Thank you, Ryan. Sorry for the bouncing around of the ordering here, but appreciate you. Let me go back to Ann Sawson, and then we'll pick back up on my error to move out of order. But Ann, over to you to talk about rural.
Thank you so much. Good afternoon, everyone. I'm one of the authors of the paper, Reimagining Rural Health Equity, Understanding Disparities and Orienting Policy, Practice, and Research in Rural America. Today, I'd like to use my brief time to do three things. First, I'd like to provide a brief overview of the 5 principles that we put forth in this paper. Second, I'd like to discuss the definition of rural health equity that we propose in our paper. And finally, I'd like to comment on how we hope that this work will be used. I hope these comments offer an invitation to read the paper in full. In our paper, we articulate 5 principles to guide policies, practice, and research in rural America. This work draws on our expertise in public health and medical anthropology and research and practice in rural northern New England. These 5 principles are oriented by an understanding of rural communities and regions as dynamic and heterogeneous settings that are experiencing profound social and economic changes. First, we propose that rural health equity is equity and propose a definition of rural health equity that I will discuss in greater detail shortly. Second, we call attention to the need to center rural disadvantage in policy, practice, and research. Third, we advocate for attention to rural health equity across the lifespan. We suggest that conversations and action narrowly centered on aging demographics do not sufficiently attend to the disparities in early and midlife, the role of younger people in shaping health outcomes, and the impact and unintended consequences of many policies on younger rural populations. Fourth, we call for diverse methodological approaches in addressing rural disadvantage. Notably, we highlight the opportunity for rigorous qualitative and community-based research methods. Finally, many accounts have centered the challenges and constraints facing rural America. We argue that close attention is also needed to rural strengths and assets. I'd like to talk about how we define rural health equity in our paper briefly. Scholars and practitioners define rural health equity in various ways. Some view rural health equity as primarily concerned with differences between urban and rural places. Others view it as centered on groups within rural places. In this paper, we suggest that COVID-19 revealed the need to move beyond conceptualizations of rural health equity grounded simply in geography, demography, or poverty, or focus simply on groups experiencing disparities within rural places. These definitions, we argue, ignore features of rural economy, community life, and the healthcare landscape that structure vulnerability to infectious disease and other health threats, including the concentration of meat packing plants, incarceration facilities, and extractive industries. Similarly, the current H5N1 outbreak is concentrated in rural dairy farms, heavily reliant on a precarious immigrant workforce. In this paper, we propose defining rurality as a distinct dimension of health equity centered on rural disadvantage and not simply rural geography. Rural disadvantage reflects the interaction of global and local historic, economic, environmental, social, policy, and institutional arrangements that adversely shape the dynamics of health in rural regions. We further note that rural disadvantage may intersect with other dimensions of equity, including structural racism and ableism. For example, rural people have a prior prevalence of disabilities, which in part reflects greater occupational exposures and more limited rehabilitation care. Rural people with disabilities may also encounter less accessible built environments, more limited access to specialized care, and stigma regarding disability. Attention to the ways that place-based disadvantage intersects with ableism is essential to advancing equity in this context. Advancing rural health equity, we argue, requires systematic and explicit attention to rural disadvantage in the design and implementation of policies, practice, and research in rural places. While recognition of rural policies and rural populations in key policy decisions and health equity strategies provides an important point of departure, we note that the inclusion of rural people does not automatically translate into attention to rural disadvantage in policy decisions, institutional practices, and programmatic initiatives. In our paper, we highlight several examples that illustrate the ways that inattention to rural disadvantage generates inequities. We encourage stakeholders to embrace a stance of systematically asking how existing or proposed policies and practice, including those not specifically targeting rural places or populations, might advance or undermine rural health equity, instead of viewing rural health equity as a siloed set of activities or unidimensional initiatives. I'd like to conclude my comments with a discussion of how we hope these principles might be used. It's our hope that these principles will help to guide policymaking, practice, and research in rural America on both emergent and longstanding challenges. We note in the paper that actions to support or impede rural health equity are embedded not only in policies, but also within the everyday practices and decisions of stakeholders at the federal, state, regional, organizational, and local levels. Systematically attending to rural disadvantage and strengths reframes rural disparities as amenable to action instead of inevitable consequences of geography, poverty, or demography. Finally, I'd like to thank the many who have contributed to this work, including rural health care, public health, and community leaders who have generously shared their insights and experiences as part of our rural research in Northern New England. We also thank the anonymous reviewers of our paper for comments that substantially advanced our thinking and improved the final commentary. Thank you for engaging with our work today.
Thank you very much, Anne. We'll now turn to Carrie Crone.
Everyone, good afternoon. Very excited to be here and be talking about one of the papers in this issue. Excited to be presenting on behalf of the group that has worked on this, my co-authors, which you can see listed here. We as a group have been interested for several years now in community health needs assessment documents that I'm going to be talking about today, and really in a lot of documents that some federal and state requirements require to be made publicly available. So today I'm going to talk about Ohio Presents Opportunities. Community health needs assessments and corresponding implementation strategies have been a requirement of nonprofit hospitals to be made publicly available since the passage of the Affordable Care Act. These are done on a triennial basis, and like I said, made publicly available through the web. Our team's been working with these documents for some time to conduct research on both the prevalence of community needs and how hospitals are approaching them in their implementation strategies. Ohio, like some other states, has recently been looking at policy changes that would result in local health departments also being required to make publicly available similar documents. In 2013, Ohio established a requirement for all local health departments to apply for accreditation by 2018, which would require them to also be creating community health needs assessments and implementation plan documents. One key thing Ohio's done is that they're putting the health departments on the same triennial cycle as hospitals, encouraging that these organizations these multi-sector organizations, rather than maybe duplicating efforts or each individually assessing a community. By putting them on the same cycle, the hope would be that they could share resources, collaborate, work together. In fact, in the IRS guidelines, hospitals are already required to seek input from local government officials, public health being encouraged, as well as from communities. Ohio's policies have created an expectation also that health departments and hospitals by 2020 would be aligning some of their efforts with state documents and identified needs as well. So our team has studied documents produced at this transition point, and while other states are considering policies such as this, to try to understand alignment both in recognition of community needs and the strategies that they are undertaking to address them. If we could move slides. At a high level, the things that our findings are showing is that there is consensus on top needs, both when we look at the needs assessment, identifying needs within communities, and when we look at the implementations plans or strategies being written about to address these needs. And so in this, what we have done to determine this idea of alignment is download these documents for all hospitals in the state of Ohio and link them to their corresponding local health departments. So all 88 local health departments are represented in our data, but only linked to hospitals on this question of alignment in counties that have a hospital. And you can see here the top needs, and these, in fact, also, even before this requirement in Ohio has taken place, these top 3 needs also align with state needs identified in documents in Ohio. But mental health, substance use, obesity, these are persistent, identified by both types of organizations. And also, you can see, maybe not to the same degree, but do carry over to the different areas that these organizations are making plans to address these needs. What is maybe more interesting, though, is when we leave these top 3 to 5 needs and we see some of the, in our protocol, some of the needs that we went looking for and identified, they become more varied as we move down as far as what organization is looking to do it. And in fact, they're more varied when it comes to implementation strategies or implementation plans than they are in assessing needs, which hopefully makes sense that both of these organizations are in the same community. The needs are the needs, and it's just through their process, or are they seeing them? But when it comes to addressing the needs, it might be reasonable that organizations, given their resources, given their strengths, given what they already have in place, might actually be looking to address different needs. It is worth noting, I think, the SDOH, or social determinants of health category that we see here. This is one that we do see variation, that local health departments are identifying this as a top need at a higher rate than hospitals. We could also go down the lines of looking at maybe more clinical things. And so when we look at where different strategies or implementation plans are being created, the place where we see hospitals as organizations maybe more eager to address these or right to addressing these would be things like heart disease or cancer, very specific and clinical areas. So there's a lot about multi-sector collaboration that makes sense. Again, sharing resources, pooling expertise, even learning about different missions, intentions of the organizations from each other. Involving different networks that these organizations have and hearing a wider range of community voices. I think it's also important, again, as we're looking at documents like these that have a lot of potential on both healthcare, health, and communities, that we're not duplicating resources to over-assess communities or assess the same communities multiple times when things can be shared. Our findings show that collaboration is already occurring before some of these policies take effect in Ohio. And again, Ohio is not alone in looking at this. States such as New York and Maine, Massachusetts are looking at doing different but similar things. And we wanted to establish a baseline to show that there is alignment that exists and try to better understand that alignment and the nuance of collaborating, working together, partnering, but maybe not duplicating efforts or exact ideas. So it's interesting to see where the differences are and think about what might be. And what we see is that organizations may be emphasizing their own strengths and capabilities in their strategic approaches. So overall, We look at promoting collaboration and alignment making sense in many ways, but a conclusion could be that communities may also benefit from strategic divergence in how these organizations specifically target to address these problems. Thank you all very much.
Thank you, Corey. And last but definitely not least, Omid Haderi speaking about the experience in Baltimore.
Hi, everyone. Thank you to the previous panelists. My name is Omid, and I'm here to discuss our article titled Co-locating Syringe Services, COVID-19 Vaccination, and Infectious Disease Testing. And this is drawn from our experience during the COVID-19 pandemic. I'd like to thank my co-authors as well, all of whom are from our partners who I'll detail in my slides. Next slide, please. So I'd like to start by acknowledging that in the last few days, the New York Times has published articles detailing the overdose crisis happening in Baltimore City right now, and how for a city of its size, it is greatly outpacing the rate of overdose deaths. And next slide, please. How this is particularly present in the Black population and Black older population in Baltimore City, really highlighting inequity in overdose deaths in the city of Baltimore. I'm also anecdotally on a lot of listservs for harm reduction organizations and groups doing a lot of work outreaching to communities affected by the overdose crisis, and really how the context of their work has not quite been captured in the popular media quite yet. So I hope with today's description, we can talk about how individuals are interacting with people who use drugs and people who inject drugs, and how that can be a pathway for reaching this population from a public health system. Next slide, please. So generally, what is the problem? And particularly, we're thinking about this time from 2020 to 2022, where overdose deaths in the United States were climbing and peaked. During the COVID-19 pandemic, risk of infectious disease continued to remain high for people who use drugs, and particularly people who injected drugs. And as a third layer on top of all this, COVID-19 infection, rates of hospitalization, and mortality was higher for people who use drugs compared to the general population. Traditional health systems are not well suited to meet the needs of this population. This is due to historical stigmatization by traditional health care and public health systems, feelings of strong stigmatization, and also difficulty with access to care. We're going to talk about how we delivered COVID-19 vaccinations to this population through the venue of a needle exchange program. But as you all remember, during the time of vaccine rollout, many mass vaccination sites required you to have an appointment in person, utilize online booking systems, or do it through health venues where it didn't account for the needs of people who use drugs who might not have access to these types of technologies or ability to sign up for COVID-19 vaccinations. So harm reduction programs that really are forward-facing and meet the needs of this population were a venue for us to deliver essential preventive services, and also can be a venue for bolstering health services for this population. Next slide, please. For us, we were partners from Johns Hopkins Medicine, the Johns Hopkins School of Nursing, particularly its Center for Infectious Disease and Nursing Innovation, and the Baltimore City Health Department. The Baltimore City Health Department runs the longest operating needle exchange program in the United States. And particularly, I'd like to commend them because during the COVID-19 pandemic, while they had to shut down for a short period to understand the extent of the pandemic and how they could keep the harm reduction workers safe on the van, they quickly redesigned their program and opened, recognizing that their needle exchange and harm reduction program was an essential service to people who use and inject drugs, and its importance of maintaining a regular schedule. So building on that long-term trust that they've had in the community, we co-located from Johns Hopkins Medicine their mobile vaccine unit to deliver COVID-19 vaccinations to this population. And with the Center for Infectious Disease and Nursing Innovation, we conducted HIV, hepatitis C, and syphilis point-of-care testing, as well as swabs for gonorrhea, chlamydia, and trichomonas for other STI testing. As far as testing went, anyone who tested positive on site was linked to care, and we tracked our linkage outcomes. And anyone who had a swab taken was contacted for follow-up care and linkage to treatment, or just treated over the phone for any positive tests. Finally, we tried to, as best we could, have consistency in follow-up vaccine clinics. So for any individual who accessed an mRNA vaccine and required second vaccination, we would be back in 3 or 4 weeks' time at the same location to do the second vaccination. Next slide, please. So this is just a picture to give you an idea of what it looked like in practice. We were literally on vacant lots, setting up pop-up tents, bringing our van up to the site in the same place that the needle exchange operated. We, from the viewpoint of people who were accessing needle exchange programs, we tried to make this as seamless as possible, navigating folks to infectious disease testing and or vaccination based on whatever their needs were in the at that moment. And from our internal evaluation, I'd like to highlight some of our findings. So of the individuals who accessed at least one infectious disease test or at least one COVID-19 vaccine, 58% of those individuals were tested for at least one infectious disease test. And all the individuals who tested positive for HIV were linked to care, or in the case of one individual who reported an HIV exposure, was prescribed post-exposure prophylaxis on site. There is, from our evaluation, room for improvement regarding hepatitis C linkage, however, and how we can reimagine how we can either link people better to hep C treatment, or, as I'll talk about in our conclusions, just do it on site. And then finally, this is a great proof of concept for individuals to see that STI testing, while it's traditionally done in the primary care setting, can be done on an outside venue in open spaces where we use privacy tents to do this. Next slide, please. I'd like to highlight that with our vaccinations, we had a 94% completion of a primary vaccine series. So this was completion of one Janssen vaccine or 2 doses of an mRNA vaccine, and 91% of individuals who received 1 dose of an mRNA vaccine received the second dose of the vaccine. So really highlighting that this is a population, when you provide care services in the setting of a harm reduction program that they have high trust in, do return for follow-up vaccination and care. But to also point out that booster rates did fall when there was a gap in times where we could provide these co-located programs. So consistency in program and programming is important. Next slide, please. This just shows our average of harm reduction services that were provided, that over 8 clinics, we had over 3,000 syringes distributed, an average of 1,500 returned to us, and we were training at least 20 to 30 individuals at each clinic for naloxone and doing distribution. Next slide, please. I'd like to highlight in our 2 high-level conclusions that we leverage the consistency of a harm reduction program that's been in the community and providing meaningful services to this population to undo a lot of the historical trauma and stigmatization that has occurred from healthcare and public health systems. We have to leverage harm reduction programs, including needle exchanges, and bolster them to provide more preventive care services and even expanding into primary services for this population. Next slide, please. But this is not possible with current funding structures. We had to use a braided approach of bringing in multiple funding sources and had to be very careful in who did what because of these funding sources. Having funding that can allow us to be flexible in how we reach out to this population, how we bolster these harm reduction programs, will not only allow us to expand services into this population, but will allow us to be flexible to the needs of the population, particularly as other outbreaks start to emerge, and how we could be responsive faster in time. Next slide. I'd like to end here and go to the next slide and thank my partners, including the Baltimore City Health Department and the Johns Hopkins Mobile Vaccine Team and the Center for Infectious Disease and Nursing Innovation, all of whom were great partners in this field work and co-authors on this article. Thank you.
Thank you all for getting us through some really complicated material. I do find the focus on community and community power really gratifying for the number of the profile of these papers in the issue. Given the size of the group and the amount of time we have left, I'm probably only going to get through a couple of questions, but let me start with this one. Whether we're talking about power building or aligning priorities, there is this question of what is the unit? What do we mean when we say community? What do we mean when we say rural community, when we say neighborhood, when we say hospital? Corey, you're noting the alignment there between hospitals and counties. This is I don't want this just to be sort of a conceptual philosophical question, although I'm sure we could treat it as such, but particularly in the context of trying to harness community voice and community power, how do we think about what the community is so that there is a unit that can do that and speak its power to an entity that has power, if that's the right way to say it. Anyway, it's very much on my mind. Would love to hear thoughts from anyone who has them.
I can go first because part of my response to this is somewhat technical. Somewhat technical in that the IRS, one of the requirements, and one thing that should be recognized is these community health needs assessment documents and others that are produced and made available. Again, we see a lot of potential in them. They vary greatly. They vary greatly in how they're formatted, what they look like, how detailed they are, and even if they meet all the requirements. The IRS does ask hospitals to address specifically in the document somewhere how they define their community. County is often chose. I think it is a convenient definition. We use county because we are linking to a health department, and there are local health departments that serve counties. There are also city health departments. They weren't brought into this. That's something maybe to look at in the future, is how city and county health departments, when they both operate, work. But yeah, so I'll answer the technical piece. Want to hear from others. The last thing I'll say is I think it's really interesting. I think some of our language around these things needs to be more specific. We say community, we say population health. Sometimes population health can mean a population I'm hoping to be my customer, as far as they have a specific disease I could treat, whereas other people see population health as like anybody who could theoretically have their health improved with resources from my organization. So those are some of my aspects of this.
I can pipe in here. I think community is defined in so many different ways. It could be like a big community, like a Black community, or it can be a little community, like this little neighborhood. And I think that, when I think about sort of like empowering community, it's about sort of what is the community? What do people out there consider to be their community? Is it their church and the sort of 500 people go to their church, or is it sort of like their entire sort of like sector of Boston? I think it's hard for us from the top down to say, hey, this is a community. It's really who do people feel like they have an affinity toward, who they feel safe around, that they have a shared experience. I think that's how I think many people define community.
I'll jump in to say, yeah, I think this is why, we've found, and this work is really oriented toward the acknowledgement that public health writ large has so much to learn, particularly from grassroots organizations and organizers who, for decades now, across many issues and areas and sectors, have been building sharp strategy, sharp bases, doing clear education and development among member leaders who are, again, the people who are most directly harmed by systems of inequity and marginalization and targeting, and that they do it in a way that is both sharp, again, in terms of strategy for structural change and focus on policy change and real systems change at a grassroots level. But it's also rooted in community experience and the joy that Ryan named. And so there's room, the organizations like grassroots organizing networks and groups at a local and national level have all of those components. And I think we have so much to learn from them. Omid talked about the harm reduction space and movement. That's a movement and a space that has now spent decades building both that deep community connection, again, and care that's really based in reflecting lived experience, but also they're in decision-making spaces and halls now, because they've developed that power together over time. It takes time, but they've developed that.
And I'll add something from the rural perspective. The rural places are often seen as just geographically determined, but we also see that they're socially constructed, both by external actors as well by communities themselves. And often we see an erasure of certain groups or the ways that communities define themselves. So I would encourage us to think very about the complexity around how we define community, how they define themselves, and what those definitions offer, but also what they obscure.
Well, I'll keep going with questions. Someone in the audience asked Ryan if you could give concrete examples of the kinds of questions that you think maybe would be more appropriate. And I'm going to use that. So I definitely want you to answer that question if you don't mind. But I would also like to use it as a point of departure to this, to me, what seems like a key power question, which is, to what degree is the goal here to use the power to change the behavior of the structures that have the power, and to what degree is it to work around them because they're so entrenched that they're unlikely to make those changes? I suppose the answer has to be both, but I'm actually interested in where the emphasis ought to be. Ryan, if I could turn first to you to answer the question from the audience, that'd be helpful.
Yeah, for sure. I mean, there's a lot of examples, and some of them are described in the paper in the reports that we generated, but something that kept repeatedly coming up is, again, the emphasis on asking people like what's wrong with them and not asking them anything else, right? There's no room for anything else in there, right? And so we talk about health, but we're so focused on unhealth and illness and the lack of, and we don't want to have any other story come forth in our data, apparently, I guess. And then some of the ones that we're more used to, I think, as an epidemiologist and former head epidemiologist from health department, like, we want to figure out the inequalities between communities, right? So we talk about communities, I'm thinking like a denominator, right? We got to standardize and compare. There's a rationale for that, but sometimes it just doesn't matter. Sometimes there's like just this one neighborhood that even if they're better off in this other neighborhood, that doesn't mean you don't do anything, you don't make any investments, you don't help them further their own pursuits, right? And so something that came out of this work was that we asked these questions through Burfus and other surveys, like, have you done this in the last 30 days? Have you smoked this? Have you eaten this many vegetables, right? But we asked no questions about context, right? We don't ask them about their neighborhood conditions. We don't ask them about stress. We don't ask them about anything else. And so we have these 30-day windows that we think we're getting something about a story, but there's no social or political context, right? So you're asking about whether you smoke, but you're not asking about tobacco advertising. You're asking about whether people are eating vegetables with environment, right? And then not only that, when we use the data, we're not tying that back to any system or structure of power that state governments or federal governments or local governments have control over to alter those broader contextual things, right? And I think this gets back to this idea of community power, right? We need to produce survey questions that can be mapped back to identifying structural things, not these behavioral things about whether I smoked or not. Tell me the bigger picture. Ask survey questions that allow us to expose and illuminate the power structures behind the data that we're seeing.
So I wonder if anyone wants to go broader into this notion of I'm really struck, Sophia, with the comment that public health doesn't get power building and power building organizations don't get public health. So one approach here is to try to get each other better, and another is to acknowledge the separation and try to work around. And I'm just curious how those of you who work in the power space react to that. Or should it all be about trying to get each other?
I think it really depends. Is that a bit of a cop-out?
No, I expected a sort of and kind of answer, but I didn't want to give it. I wanted someone else to.
It depends so much on the structures and how entrenched and how interested everyone is in talking to each other. Sometimes you just have to solve the problem separately because, we had organizations that said, please, I don't want the public health department in my meeting. I don't want the hospital in my meeting because I'm scared of them. Whereas others said, yes, of course, we want to work together. That's how we're going to get this done. And so I think it really depends so much on the conditions of the specific place and the particular problem that we're trying to solve.
Yeah, I mean, I appreciate that answer, and I'm thinking of the range of locations where people are trying to build power and how hospitable or inhospitable those locations are to these kinds of conversations. And I guess that's what animated my question, is that I think there's I hope you'll forgive me if you disagree, and you'll say something if you disagree, but I think there's a tendency in this work to overemphasize places where there is sort of a synergy on high-level goals, but maybe disagreement on methods. In many places, there's real hostility here, and it seems to me that we have to have that in mind as we're thinking about strategy.
And if I could quickly add
Yes.
when it comes to work with people who use drugs, and particularly these grassroots organizations, there is rightfully hostility towards public health organizations and healthcare organizations. So presence is very important. The only reason we were successful is because the Baltimore City Health Department's needle exchange has been operating since the late 80s. We have built on decades worth of other people's presence and hard work in order to do that. And I also see this in other ways of public health might co-opt what are communities' structures for building power. So I see this a lot in harm reduction, where it's really a philosophy for communities of people who use drugs to keep each other safe. We cannot just operationalize that as handing out fentanyl test strips or only Narcan. While these are very important harm reduction tools that we can use, it is inherently a power that we should afford to people who use drugs and be present to meet their needs rather than co-opting it. So again, it doesn't necessarily answer the question, but just an understanding that the community has a lot of strength in this, and enabling that is important.
I really appreciate you bringing that up. We just had a issue devoted to the housing and health, and there was a paper on clearing tent encampments and how destructive that can be to the resources built in those communities, despite the limitations as well. And so this notion of asset and what's there as opposed to what's not. So let me just close. We're at the end of our event here. A lot of talk in public health about trust. A lot of broken trust. I appreciate, Omid, your last comment about that. So I just wonder, I'm hoping we can end on a positive note about the ability of engaging communities in an authentic way to build trust that is deserved, not manufactured, and how we go about doing that. And so a lot of you have experience doing exactly that. So I'd love some closing thoughts on authentic building of trust at the community level to support public health. What do we do? What does it take?
I guess I can start us off. I'd say it starts by listening to communities and giving them voice, and letting them lead, and a lot follows from there.
I agree. I think showing up, as Hamid said, like show up, number one. Number two, like listen, and then keep listening and keep listening. And I think number three is to help communities get things done and get real results.
Yeah,
Echoing what's said, anecdotally, I know a story of a hospital working on a health needs assessment document where the community insisted poverty be one of the top 3 health needs, and the staff of the hospital didn't know how that could be one of their health needs. What could they do about that? But to their credit, they carried it through on the documents. So genuinely listening communities, and following through, which are some of the intentions of these things.
Thanks, Corey. Yeah, and to build off your last question, Ellen, I think the relationship building piece is really critical, and just the learning and acknowledgement of what folks don't know on both sides, which we did find in our assessment. Getting to know each other as humans, it sounds trite, but it's true. I think something that I've long thought and we saw reflected in our findings was that public health, we're so good at the kind of, larger scale analysis and data, but what can get lost is some of just the grounded one-to-one interactions and relationships. And so and then the relationship building toward a larger goal and being clear about what the larger goal is. But, something that we can borrow from organizing spaces too is the practice of one-to-ones, which is really focused on understanding each other's motivations for the work in the first place, what our histories are. And then through that, identifying common goals, common interests, and not just to say, oh, we're exactly the same, or we're similar in all these ways, but then to identify the places where you can act together. And then I'll just say, because I know we're very short on time, that something I also hear often from organizers is to move from transactional relationships to more transformational relationships. And so folks do appreciate it when we can sign on to things and, sign a support letter, et cetera, maybe for a campaign or a legislation for those of us who can do that. But what does it mean to keep showing up and getting, and easier said than done, given all of our capacities sometimes. But I think that's where if you've gone out to coffee a couple of times, just made that effort, you get to, folks know how to reach you, where to connect, etc., and that we shouldn't minimize that.
I'd second that, and also I think Alice's point, showing up, but also changing how we show up. The trend moving towards transformational for sure, but also like keeping in mind that public health, whether it's academic or in practice settings, we are intrusive and intermittent. Like that's what we are. We show up when we need to show up, when we're told to show up, when we're paid to show up, right? We're not building relationships. We're not sitting and having coffee. The only time we show up is when it's in our interest, right? And so I feel like just changing the vibe that we have, the energy that we have, and remembering that like most folks would think about public health as an entity, not as a person. So thinking about how we humanize who we are and what our work actually entails, right? And I don't think we can do that in our standard processes, right? Folks are used to understanding and seeing themselves through public health, through the stories that we tell, that we conjure up, through our data, through our advertisements, through our billboards, through our vaccination campaigns, right? That's how we are showing that we see them. And so they don't really see who we really are. And we don't apparently understand who they really are. So I think not just showing up, but changing how we show up so that we can actually have those real relationships to be transformational.
Well, I'm going to let us end there. What a great way to end. And it circles back to the topics we started with about who are the workforce and what do we expect of the workforce to do in its relationship to the community. So thank you all for an excellent panel. I know it's been a long session. To the audience, let me just wrap up with some thanks again. I do want to acknowledge the financial support we received from the California Endowment, the Robert Wood Johnson Foundation, the Kaiser Permanente Fund at the East Bay Foundation, the Big Cities Health Coalition, and the Public Health Accreditation Board Center for Innovation. I acknowledge our advisors and all of our authors and our editors. It took a tremendous effort to pull this together. This event was recorded. We'll make it available. You can also find more on our website with additional events related to the content. On June 18th, we'll have a journal club with author Clara Long about community power building groups and public health non-governmental organizations. We also have an insider program. This event, of course, was available to everyone, but if you become a Health Affairs Insider, you'll have access to content beyond the journal, exclusive events, curated email newsletters, and more. You can sign up for that on our website. So with thanks to all for what it took to make today happen. I appreciate the audience's engagement, participation, the questions you asked. And with that, we are adjourned.